Welcome to week 2 of the session. What I really hope for you for this week is to build upon the information that was covered in week 1 and to go over some new information, learn some new skills, and feel more confident as we go each week. From here on, each week in the video, we'll take some time to review on the previously learned information so you'll have a time to refresh on that previously covered material. So let's go ahead and start with our review for the week then. The skull, also known as the cranium, consists of 22 bones, which can be subdivided into 8 cranial bones and 14 facial bones. The main function of the bones of the skull is to provide protection and structure. Embryologically, the skull derives from ectodermal neural crest and the mesoderm. These particular early developments start in about the 3rd week of gestation, which means that if there are disturbances during an early part of a pregnancy, there can actually be some permanent lifelong alterations to the development of the skull, to the development of the brain. For example, if during the pre-implantation period, which is very early on in a pregnancy, within the first couple of days before the embryo is actually implanted into the uterine wall, if the meiosis that is occurring, the cell division, is disturbed, it can result in an extra chromosome, which we know as Down syndrome, and can cause developmental and physiological problems down the road. During the embryonic period, if the mother were to contract the rubella virus, this can cause the baby to be deaf or even develop cardiac defects. High levels of radiation can stunt growth, cause mental retardation, or even cell death. And this is also where ingesting alcohol can result in fetal alcohol syndrome. This is a lifelong condition. It can't be cured, but obviously it can be prevented by not consuming alcohol during a pregnancy. It is possible that even small amounts of alcohol consumed during a pregnancy can damage the developing baby. Now there's an umbrella term. It's like a spectrum disorder where they could have partial fetal alcohol syndrome, where some of the characteristics of fetal alcohol syndrome are present, such as changes to their facial features, but they don't have all of the symptoms of fetal alcohol syndrome. Alcohol-related neurodevelopmental disorder. People with this disorder experience some or all of the following of impulsiveness, inattentiveness, challenges with judgment and problems with school performance and other issues with law enforcement later down the road. Alcohol-related birth defects are physical birth defects, abnormal changes to the body affecting the heart, eyes, skeletal system, ears, and kidneys. Neurobehavioral disorder associated with the prenatal alcohol exposure is someone that was exposed to more than a small amount of alcohol as a fetus, and they have difficulty with daily tasks like bathing, can struggle in social settings because of significant behavior issues, tantrums, trouble with thinking, and memory. Using some of the most up-to-date information from the Centers for Disease Control, or the CDC, and other scientists, they estimate less than 2 cases of fetal alcohol syndrome a year in every 1,000 live births in the United States. But this could be higher when we think about our patients who may just not feel comfortable talking with their healthcare provider about the fact that they consumed alcohol. And because this is a broad spectrum of conditions, it's possible that it may go undiagnosed. In 2019, CDC researchers actually found that 1 in 9 pregnant people drank alcohol in a 30-day period. The alcohol will pass through the bloodstream to the fetus through the umbilical cord, and the baby can't metabolize or break down the alcohol the same way that an adult does. So it stays in the body for a much longer time and interfere with normal development, particularly the brain and central nervous system. The alcohol can kill cells in different parts of the fetus, It interferes with the way that nerve cells develop and how they travel to form different parts of the brain and their functioning. And obviously, alcohol itself constricts blood vessels, which slows the blood flow to the placenta, causing a shortage of oxygen and nutrients to the developing fetus. Toxic byproducts are produced when the body processes alcohol, and then they can concentrate in the baby's brain cells and cause damage. But this is just one of the many ways that the actual cranium and the brain and just different parts of our patient may be affected in utero before the baby's even born. And then lastly, during the fetal period, if a mother were to be prescribed tetracycline, it is prescribed to treat infections caused by bacteria, including pneumonia and respiratory tract infections, certain skin, eye, lymphatic, intestinal, genital, and urinary system infections, and even other infections that are spread by ticks, lice, mites, and affected animals. So you wouldn't think that it would be harmful, but if a mother were to be prescribed this and ingest it during pregnancy or nursing or during the developmental period of the secondary and primary teeth, so even if a child were to get it prescribed to them when those teeth are developing after birth, it can create tetracycline staining, which ranges anywhere from like a dull-ish gray look to their teeth to a very severe dark gray staining. And because it is something that's internal to the tooth during development, it's not as easily rectified through tooth whitening as if we were considering, tobacco staining is a little bit easier to take care of than a tetracycline stain. In week 12 of a pregnancy, the palate finishes forming inside the mouth, and if that's interrupted, it can result in a cleft palate. These are openings or splits in the roof of the mouth and the lip. We'd consider that a cleft lip. And cleft palate is a common birth condition. It can occur alone or part of a genetic condition or a syndrome. And symptoms are going to arise from the opening in the mouth, including difficulty speaking, feeding. There are surgeries that can restore the normal function with very minimal scarring, and speech therapy afterwards can help correct any kind of speech difficulties post-surgery. So that one can be treated, but we're hoping that doesn't happen in utero. In addition to the bones of the cranium, as a dentist, there are other considerations that need to be taken into knowing the nerves and the muscles of the face, because there are several cranial nerves that are going to branch out into, obviously, the cranium. So you have the olfactory nerve, the optic nerve, the trigeminal nerve. There's all of these different nerves that are running through the bones superficially, like laying on top of them. The biggest one that we kind of refer to in dentistry is going to be that trigeminal nerve. The trigeminal nerve is the one that branches down into like the maxillary arch, which is the upper arch of the mouth, so those upper teeth, the mandibular arch, which is the lower arch of the mouth, the lower teeth, into the tongue area, the lips, the cheeks. All the sensation around those is what we're looking at when we discuss that trigeminal nerve. Now, the nerves may provide sensation, but also receptors for information from the muscles to and from the brain. And there are obviously lots of muscles that lay on top of the cranium. They aid in chewing, speech, moving the eyes. There's lots of them that as a dentist that they're going to want to really pay special attention to, knowing where they are so they don't damage them during procedures. Now we have two views of the skull here. We have a lateral view and a frontal or anterior view, which allows you to see the front facial bones that provide the bony support for the eyes and structures of the face. So let's go through some of these bones here. We'll start with what some might call the brain case. The brain case is what contains and protects the brain. The interior space that's almost completely occupied the brain is called the cranial cavity. It's bounded by the rounded top of the skull, or the skull cap, along with the base of the skull, or the floor of the brain case, and it consists of 8 bones. These are the paired parietal and temporal bones, plus the frontal, occipital, sphenoid, and ethmoid bones. When we're looking at the parietal bones, it forms most of the upper lateral side of the skull, and these are paired bones, meaning there's two of them, with the right and left parietal bones joining together at the top of the skull. It's bounded anteriorly by the frontal bone, inferiorly by the temporal bone, and posteriorly by the occipital bone. Now, what those terms mean: anteriorly is toward the front, posteriorly is toward the back, inferiorly is below. So when you hear those terms, just kind of picture where they are here on this skull. The temporal bone is what forms the lower lateral side of the skull, or the sides of the skull, and contains the external acoustic meatus, which is the opening to your ear canal. The frontal bone is the single bone that forms the forehead, and at its anterior midline, or the front middle, is between the eyebrows. There's a slight depression called the glabella. The occipital bone is the single bone that forms the posterior or rear skull and posterior base of the cranial cavity. The sphenoid bone is a single complex bone of the central skull, and it serves as a keystone bone because it joins with almost every other bone in the skull. Like if we were putting together a puzzle of the skull, this would serve as like the cornerstone that all of the other puzzle pieces would have to stick to. Another singular bone is the ethmoid bone. It's a midline bone that forms the roof and lateral or side walls of the upper nasal cavity, the upper portion of the nasal septum, and contributes to the medial wall of the orbit or the eye socket area. You will notice the zygomatic bone, which is purple on the diagram here, connects the temporal bone to the frontal and the maxilla. This is what we would kind of think of when we talk about our cheekbones. And the maxilla and the mandible are going to be those two bones that you hear referred to all the time in dentistry, because the maxilla is what contains the maxillary arch, which means the upper arch. So really commit that to brain. Maxilla is the upper bone. Maxillary is the upper arch, or the teeth that are in that upper jaw. Then you have the mandible, which is green here, like a lightish green, and that's going to be your lower jaw. The mandibular arch is all of the teeth that are in that lower jaw, which is the mandible. And this is a hinging bone that rests up into the temporal bone at a joint that we call the TMJ, the temporomandibular joint. There's a joint on the right and the left that connect that lower jaw to the skull, and they are what allows that jaw to slide and rotate in front of each other for speech and eating. I'm sure you've heard people say that they have TMJ, which is, for the most part, completely true, because everyone should have a temporomandibular joint. But what they are trying to convey is that they have a TMJ disorder, which is a type of disorder of the joint itself, which can cause pain in the jaw when they speak, eat, and it's really different from person to person. It could be as a result of someone who clenches and grinds their teeth. It could be someone that chews. It could be because of an issue post-surgery. But there's a lot of pain and tenderness, aching around the ear, difficulty chewing, facial pain, locking of that joint, making it difficult to open or even close the mouth. Now, there are some less invasive treatments of it where a patient may get like a night guard or even a day guard to wear in their mouth, take anti-inflammatory medications. They can do massage therapy, or there may be more invasive surgical injection type procedures to try and alleviate the pain as a result of the disorder. Now, when you are going through and you're studying this lateral and this frontal view of the skull, please note that this is something we are going to assess you on. We're going to use this diagram with all of the terms removed from it. They'll be labeled with a number, and so you will have to be able to know what each bone is on the skull. It would also be an important thing to note the sutures throughout the skull. The sutures are where the bones have formed and fused together, such as the coronal suture is what connects the parietal bones to the frontal bone. on the cranium itself. There are additional structures that we could discuss about the anatomy of the bones of the skull, but what you see here is what we will test you on. It won't be anything additional to this. Every tooth in the adult and pediatric dentition, or the set of teeth that they have very unique structures to them, from a front tooth to a back tooth, but there are some anatomical structures that every tooth will have in common. These 14 items listed here are what you will want to also be studying, because this will also be on your midterm exam, but it is very helpful as you are studying to not only just memorize what number they are on the diagram, because I may change these numbers on you on the exam, but also when you're looking at radiographs and different diagrams, you should be able to take this information and apply it to any other illustration or x-ray that you see, because you've committed the definitions to memory along with where they are on this diagram. So we'll go through these. Number one is pointing at that white, hard outer coating of the tooth. We call that enamel. Enamel which in a lot of layman's terms we may refer to it as gums. Gums are typically really tightly adapted to the tooth. They're soft and spongy. They haven't receded. They don't bleed when you brush and floss. Now, pigmentation can vary from ethnicity to ethnicity, but it's usually a nice pink color. It's not typically, you're not going to see it fire engine red. That would be an indication that there is some inflammation and infection. Number 4 is the cemento-enamel junction, which you may also see referred to as the CEJ. This is just a big long word to describe that at some point the protective layer of the crown, which is the enamel, is going to meet up with the protective layer of the root, which is cementum. We haven't gone over that yet. That's number 6. Meets, just like a junction, an intersection on the road where two roads meet. This is where the cementum and enamel meet. This is what we would a lot of times refer to as the neck of the tooth. Number 5 is the pulp cavity, and this is referring to the entire internal portion of the tooth where it's completely hollow. Containing the nerves and blood supply that help to keep the teeth alive. It's imperative that we catch decay or caries, for the more technical term, prior to getting to this pulp cavity, because once it enters into the pulp cavity, then the nerve has been infected and we do have to do a root canal. So as decay progresses, it starts in the enamel, in what we call incipient caries, where the enamel starts to just become demineralized, which the good thing is if we catch that soon enough and we up our dental hygiene practices, usually we can stop or arrest that decay. As it continues to spread, we call it a frank lesion. So it gets larger, it works its way through the enamel, which takes usually a little bit of time. It gets into the dentin and it spreads a little bit faster. Obviously, it's not as dense as the enamel, and then it works its way to that pulp cavity, and that's then when we have issues with those root canals. There's no way we can do a filling on that tooth. They either need an extraction where we remove the tooth, or we have to completely clean out that infected nerve tissue through the process of a root canal. Number 6 is your cementum, which is the calcified connective tissue that covers the root of the tooth, which is what number 11 is. If you think roots of a tree are in the ground, the roots of a tooth are in the bone, and so the cementum is what covers that and provides structure for the periodontal ligament, which is number 7, to actually attach to. And it has similar structures. So the cementum has similar structures physically, chemically, to that of bone. Is the protective outer covering of your tooth. It protects the crown, which is what number 12 is on the diagram, and it is going to be the hardest substance in the body. This has a really sensitive tissue inside of it, mineralized, and helps to protect the nerve of the tooth from decay and the changes in pH and acidity levels as we eat and drink throughout the day. Number 2 is dentin. This is a yellowish and somewhat elastic but mineralized avascular tissue that helps to support the enamel and encloses the pulp chamber, so it makes up the bulk of the tooth. Number 3 is your gingiva. Number 7 is that periodontal ligament. The ligament is what is attaching the cementum to the alveolar bone, which is number 8, which is the cancellous, more spongy looking, less dense bone than what you'd find in your femur. It's a different type of bone. So the alveolar bone is what the tooth is embedded into. The ligament, number 7, is what attaches the tooth to that bone. So it's not just sitting in there. It does have fibers that are attaching it to the bone. It not only attaches it to it, but it also kind of acts like a shock absorber. When you think about it, there's that buffer area that when you bite together, your teeth have some give to it. So it's not just cementum hitting against alveolar bone. And if you were to take your tooth right now, you'll notice that there's a little bit of give or a little bit of play to the tooth. You're feeling the give that ligament has around the tooth in the socket. Again, alveolar bone is what we call a cancellous bone. A cancellous bone versus a compact bone is that the bone cells themselves aren't as tightly compacted, so they're not going to be as dense as like you would find in different areas of the body where you have compact bone, like in your femur. Number 9 is the radicular pulp. The radicular pulp is not just that one particular point that it's pointing at. Think of it as all of the nerve vessels that are passing through the root. So that's the portion of the pulp that is in the root, which is the portion of the tooth in the bone of the structure. So you can also remember it as the R in radicular is going to match up with the R in root. Number 10 is the apical foramen. If we break down that word, apical means, or is referring to apex, which is the tip of the tooth. Foramen is an opening for nerves and blood vessels to pass through. So in this case, it's an opening at the apex, or the tip of the tooth, where the nerves and blood vessels go up and out of the tooth. So we have to have that entry point. You can have accessory canals, extra little openings that go out of different areas through the radicular pulp and out the sides of the root. Those can become problematic if the tooth were to become infected. We'd have to make sure that we clean out those accessory canals effectively, or else the tooth will just become reinfected. 11 is the root, portion of the tooth embedded in the bone. 12 is the crown, the portion of the tooth that is covered in enamel. And 13 is going to be the coronal pulp. So again, not just that one like spot it's pointing to, but all that pulp area that's resting inside of the crown. Just like in radicular pulp, the R matched up with the root. In this case, crown and coronal pulp both start with C. So the coronal pulp is in the crown of the tooth. And last but not least on this diagram is number 14, the pulp horns, which are the projections at the top of the coronal pulp. We will begin this week discussing the adult dentition, and next week we'll move into the pediatric or the child dentition, which are the teeth that are present normally anatomically in the adult or child mouth. There are some different ways that we can name or identify the teeth that are present in the adult mouth. And so what is super helpful in getting this information committed to memory is to color code. So pull out this sheet out of your workbook. If you don't have that already, you can download this file or you can come back to this and color code it. Just take a screenshot or a photo of this and color code when you do get the physical copy of this. But we are going to start off with some terminology that's really important, going to make it a lot easier for you to learn this information. We already talked about the maxillary arch being the upper jaw and the mandibular arch being the lower jaw. When we talk about the midline or the mid-sagittal plane, that is the imaginary plane that goes right down the center of the human body and splits us into our right and our left. Now, if you're looking at the screen, you'll notice that on the right side of the image, it says left, and on the left side of the image, it says right. This is transposed because the idea is that you are looking into intraorally the patient's mouth as though they were sitting right in front of you. So it will be the patient's right and the patient's left. This will be the case anytime that you're looking at a paper chart, a computerized chart, x-rays or radiographs on a screen. Anything that's on the right side of the screen is truly the patient's left, and everything on the left side is the patient's right. We'll start with their names. We'll start right at the midline, which is that middle line, that dotted line that goes right down the center, splitting them from the left to the right. And we're going to start with what we call our anterior teeth, or our teeth that are toward the front of the mouth. Labeled in red are our central incisors. Incise means to cut, and so these anterior teeth have that sharp incisal edge, the edge of the tooth that you would use for cutting into food, and they are centrally located. They're right at the center of the midline. These are single-rooted teeth, so if we look at them at an x-ray or when they've been removed through an extraction, you're going to see one single root for this particular tooth. The upper arch or the maxillary arch versus the mandibular arch, those central incisors are going to be larger in their shape and size than the mandibular central incisors, but they do have the same names. So your ones on the top, the ones on the bottom in red are your central incisors. Right next door to those, labeled in yellow, are going to be your lateral incisor. Lateral meaning to the side. Incisor, this one still has the same function as the central incisor, so it's for that cutting. It's got that sharp cutting edge, the incisal edge of the tooth. And these are also single rooted, but they are slightly smaller, slightly different in their shape than the central incisor. So if you look in the mirror and you're looking at those two front teeth, and usually we're going to see those maxillary ones because they do overlap the mandibular ones. But we're looking at those two teeth right on the midline. Those central incisors are big, square, blocky shaped. Then the ones right next to them, the lateral incisors, kind of look like that tooth but shrunk down a little bit. And then the last anterior tooth, meaning tooth towards the front, is going to be your cuspid. Those three types of teeth, the central incisor, the lateral incisor, the cuspid, are all single-rooted teeth that make up the anterior teeth. You have the same on the maxillary as you do on the mandibular, assuming none are missing or have been removed, which are labeled in blue. Cuspids have an interchangeable term of canine, so you may hear it referred to as a cuspid or a canine. This is that tooth that has that sharp point. People call them their eye tooth, their dog tooth, but when we're referring to it in class, it will either be cuspid or canine, and canine like the animal, not the letter K and the number 9. Now we're going to move into the posterior teeth. Posterior meaning towards the back, and so these teeth do have a distinctly different function if you were to look at them in the mirror or even run your tongue across them. The anterior teeth have that incisal edge for cutting, and then when it's time to chew, you would use your tongue and cheek muscles to move that food to the back to masticate or chew on what we call. As far as eruption period, or when the teeth actually break through the gum tissue and start to work their way into the oral cavity or the mouth, it does vary from person to person, but the average years of age that the permanent teeth, the adult teeth, come in. For central incisors, it can be anywhere from 6 to 8 years of age, depending on if it's a maxillary or a mandibular central incisor. For a lateral, we're looking at about 7 to 9 years of age. For your cuspids, we're looking at 9 to 13 years of age. Our first bicuspid is about 10 to 12 years of age. Second bicuspid, 11 to 13. First molar, 6 to 7. Second molar, 12 to 14. And then that third molar, significantly later, 17 to 21 to 25 years of age. A lot of times we'll refer to our first molar as the 6-year molar and the second molar as the 12-year molar, because those are the average ages that you're going to see these teeth erupting or moving into their functional position in the mouth. Called the occlusal surface. If you run your tongue across the flat chewing surface of those back teeth, you'll notice that there's grooves, pits, and fissures, things where food and candy get stuck down into, and you really got to scrub them clean real well. Those are going to be your posterior teeth. In utero, teeth do start to be formed around week 5 to 6, and then they will begin the eruption process around 4 months after birth. But again, we'll go over that a lot more detail next week when we get into the pediatrics. When we have the permanent teeth beginning to form, and the primary teeth roots are being destroyed, it's a process of what we call resorption. Then the permanent teeth cause the primary teeth to fall out or exfoliate. And then lastly, these permanent teeth move in and erupt. So you'll hear those terms utilized a lot in your offices. Continue to study this information as you will utilize this terminology from day one in class all the way through the rest of your career. Like, this terminology for the names of the teeth will never change. Now, numbering systems. We're going to change gear for just a moment because there is the naming system that we went through that's going to go from the midline back. But then when we utilize numbers, this naming system starts from the posterior and works its way from the most posterior upper right quadrant meaning a fourth of the mouth. So if we're looking at the maxillary right furthest back tooth, it's going to be a third molar, but we call that tooth number 1 in what we call the universal numbering system. This is also known as the American system. It's a dental notation system commonly used here in the United States. And other than the Palmer notation system, which we'll talk about when we get into orthodontics, this is what you're going to also hear you. So it's kind of interchangeable. What it does is it kind of simplifies what you're saying. So instead of me saying the maxillary right third molar, which is a lot of wording, a lot of writing, I can just say tooth number 1, and it's meaning the same thing. So if you were to put your finger in your upper right quadrant, if you were the patient, now it's going to be opposite of what you're looking at on the screen, because this is as if I were your patient and you were looking into my mouth. I'm going to be pointing at my upper right. And if my third molar is there, that would be tooth number 1. We would work successively up towards the midline to tooth numbers 8 and 9, which are the central incisors. Then swing back around to the maxillary left or the upper left. Third molar known as tooth number 16. So 1 and 16 a lot of times are missing because they're impacted or have been removed. But that does not mean that your second molars, the purple teeth here, then become tooth numbers 1 and 16, because that would get really confusing when there's multiple patients with all these different missing teeth. It would throw off your numbering system. Tooth number 1 is always the maxillary right third molar. If it's missing, then it's missing. We skip it. We jump to tooth number 2. If number 3 is missing, we just say number 3 is missing. We skip that in the numbering system. Even if through orthodontics, which is braces, if the gap where the tooth was has been closed, we aren't going to be renaming. Like, those don't change anatomically. So upper right, number 1, upper left, 16, drop down to your lower or mandibular left. That would be 17. Up to the midline on the mandibular arch or the lower arch, that's 24 and 25, those red central incisors. And then all the way to the mandibular right, your lower right or the patient's lower right, tooth number 32. So you want to know either of these. Be able to communicate whether it's through the naming system of first bicuspid, second molar, maxillary right, maxillary left, mandibular right, mandibular left, or even just as specific of saying tooth number 20. Let's do some practice here. So if I were the doctor and I said, please take an x-ray, or we're going to take a look at tooth number 14 in your mouth, try to point where 14 is about. You can even be more specific and find exactly which one it is. But let's describe tooth number 14. You can look at the screen there. Tooth number 14 is going to be in the maxillary arch, so you should be pointing on an upper tooth. It will be the left, so even though it's on the right side of the screen, it's the patient's left, and it's a first molar labeled in black there. Let's go for another one. Describe tooth number 31 for me. 31 is going to be your mandibular right second molar, to that purple tooth. Last one, and you're welcome to pause it as we're doing these. Tooth number 23. Tooth number 23 is going to be the mandibular left lateral incisor in yellow. You have what are called bicuspids or premolars. Again, another interchangeable term here. If you think of the word bicuspid, bi meaning two, cusp meaning point, so you've got 2 points to these teeth. Whereas if we were to look at a molar, they're significantly larger in their shape, and we're looking at more around our 4 and 5 points on them. But you do have a first bicuspid or premolar, premolar meaning before the molars. That is labeled in green. Then you have a second bicuspid or premolar. That is labeled in brown. And if you were to run your tongue on those, you can feel the 2 points and go back one more, and you feel that tooth is significantly larger. And it may even have an extra little cusp, a little point on the tongue side of the tooth or the lingual surface. We call that the cusp of Carabelli. Doesn't really mean anything. It's just an extra anomaly that we see on some people's teeth and others not. On that first molar labeled in black there. So if on the lingual you have an extra little sharp point on that first molar, you more than likely have a cusp of Carabelli present. These are going to be the largest of the 3 molars, and they get smaller as they move more posteriorly or more towards the back of the mouth. You get your second molars in the purple and your third molars in the orange, which is what we traditionally think of as wisdom teeth, and they usually are impacted. Even though this tooth doesn't have a flat cutting surface like the central and lateral incisor, it does have an incisal edge. It just comes to more of a point. Now, there are some people who have had these removed, congenitally missing, so they just never developed, and really that can be any tooth can be congenitally missing. It can come and erupt in the improper position, so it may be somewhere it shouldn't be, it may be impacted. There's a lot of reasons why that might not be there. So we do want to kind of get used to what they look structurally, so that missing teeth, patients that have teeth removed for orthodontics and then the spacing has been closed up, or the pediatric dentition where there's a mixture between the adult and the pediatric, we call that the mixed dentition period because they've got both. If you're trying to practice on a patient at home or family member, that's where, as a new dental assistant, it can get a little confusing. And so using this diagram, using the 3D models in class, and then someone who you're fairly confident that they have all the teeth there is a great way to practice this information. One thing that we'll be doing in our first clinicals is we will be examining the teeth one by one. We'll be naming them, we'll be numbering them, so we'll be getting accustomed to using this terminology, but also viewing it clinically inside of a patient's mouth. When we're looking at a patient's mouth and it's missing, we can quickly identify that. It is single-rooted, usually comes to a point, that cusp on the tip of it, although some people, like, they clench, they grind, and it's been worn down, and it's a little bit more flat in its structure on the tip than what you would see other cuspids. Next week, we'll cover the pediatric or the primary teeth, what ages we might see those start to erupt. And when we see those exfoliate or they fall out of the mouth, that's when the adult teeth erupt and work their way into the oral cavity. We're going to take a look at the different surfaces of the teeth today. This way we can better understand when we're communicating with insurance and other dental professionals what surfaces need to be worked on. Your front 6 teeth from cuspid to cuspid are considered your anterior teeth, and that's for the maxillary and mandibular. And premolar to molar are your posterior teeth. As review, naming them from the midline out, you have your central incisors, lateral incisor, cuspid, first premolar or bicuspid, second premolar, first molar, second molar, and lastly our third molar. When we're chewing, our anterior teeth have what's called the incisal edge, that's that sharp cutting edge, and the posterior teeth have a flat chewing surface called the occlusal surface. To better identify, I'm going to use a little bit of colored dough here, and I'm going to place it onto first the occlusal surface of those posterior teeth. Think of this when you're eating those chewy Swedish fish where your candy gets stuck. That helps us to grind up our food for better swallowing. For our anterior teeth, the anterior teeth have that sharp cutting edge on the edge of it. This is kind of like our scissors of our mouth. When we want to bite into our apple or into our meat, we use the incisal edge. On our anterior teeth, there is the front surface that you'll see when a patient were to smile. We call this the facial surface. This is the surface on any anteriors from cuspid to cuspid. When we move to the posterior teeth, there's different terminology for that same surface. It's called the buccal surface. It's near your cheeks. That's what it's resting against. For all of your mandibular teeth, on the portion where your tongue rests, it's called the lingual surface. That's going to be on all of your anteriors, on that tongue side, and it would even apply to those posterior teeth on the tongue side too. Now, this is almost a universal term. We use lingual for both the maxillary and mandibular arch, although you may occasionally hear palatal for that maxillary arch. The interproximals are where it gets tricky. Think of the interproximals as when you're flossing that space between the teeth. One surface is going to be closer to the midline, one is going to be further away. So as you floss and you hug that floss to the tooth, for example, this side of the tooth is further from the midline on that molar. It would be the distal. And then we're going to floss. We're going to hug the distal of that premolar. And then we're going to hug the mesial of the molar. There's a mesial and a distal that touch each other. And this has all to do with in relation to that midline. When we're looking at the mouth, you have what's called your midline or your mid-sagittal plane, and that's what splits our body into our right and our left, and that's right between your central incisors. On every single tooth, you have a mesial and a distal surface. Mesial meaning towards the midline, distal meaning away from the midline. So as we're looking at each of these teeth, I've starred the mesials of one side of the mouth in pink and the distals on the other side in a blue star. Now there obviously would be a pink and a blue on each of these teeth, but to keep it kind of simple, we've only split it into halves. So as you look at the molars on the patient's right, which would be the left side of your screen here, those pink stars are the mesial surfaces. Now, this isn't the surface that you see from the top. These would be the occlusal and incisal edges that you see. These are the surfaces that are interproximal. So as you're flossing, that tight area, that contact point, and when you're down into the embrasure space, that free area past the contact point, these are the interproximals. So you have your mesial towards the midline and distal away from the midline. This has got to be one of the more confusing ones to think about because it's not as simple as just looking at that flat chewing surface or the outside surface towards the cheek. So this will take some practice, but really understanding terminology that mesials towards the midline, distals away from the midline, buccals against the cheek on a posterior tooth, incisals against the lips of an anterior tooth. Facials on the lips of the anterior teeth. Incisal is the sharp cutting edge of the anterior teeth, whereas occlusal is the flat chewing surface of those posterior teeth. Keep practicing this terminology, as this is something that you will have throughout your whole career as a dental professional.
Every day when entering into the office, you will turn on your vacuum and your compressor first thing. Then fill your ultrasonic with water and an enzyme tablet. You will refill your autoclave with distilled water.
And weekly, you'll want to make sure that you run a biological monitoring strip inside of the autoclave itself. You can just run it on a regular test cycle, return it to the envelope, seal it, and make sure that you have put on your labels or filled out the information. Whenever you notice that your suction is becoming lessened or clogged or just once a week maintenance, you should make sure that you're changing out your dental traps. You can locate those typically in the units. You'll get a new one and replace it each week. Now that you've gotten everything set up and ready to go for your day, you can set up for your patient. Begin by making sure that your hands have been properly cleaned, either using soap and water or a hand sanitizer that utilizes a 70% or higher alcohol concentration. After you've washed your hands, make sure that you're not touching any contaminated cabinets like your trash can cabinet. You can get out your tray cover and barriers for the room. And the order really doesn't matter here, honestly. Just come up with a rhythm and a system so that you don't forget the different steps of setting up your room. If your room doesn't use an overhead light, maybe they have lights hooked to their loops or ones that are hands-free. You don't have to put the barrier tape on, but you can see a little trick here to make it easier to remove. After the tape, you can see here that I'm going to go ahead and put the headrest cover on. We have half chair sleeves. There are ones that are smaller that you might see in the hygiene setting where it just covers the headrest, or a full chair sleeve in a more surgical setting. I like to then go ahead and set up the procedure items, all the instruments, hand pieces, and small items on the tray itself. A general setup is going to be your HVE, placing it into the larger of the sections, making sure that the beveled end that has the hole is facing out and that the levers are shut off so that it's not continually suctioning while you're working with it. This saliva ejector, which we use for the smaller amounts of fluid, we're going to put into the smaller section that has the rubber fitting and bend it like a candy cane so it's easier to place into the patient's mouth. Next, we're going to place our high-speed handpiece onto the unit lines, making sure to line up all of the small tubes and screw it into place. Now, this may vary from office to office how your handpiece actually connects to your lines. Our contra angle or slow angle attachment simply pops right onto the motor itself. Now, each of these motors, you do want to take special caution not to send through your ultrasonic. You are going to want to make sure that they are handled and disinfected properly. The rheostat on the floor there, typically there is an on and off switch for the water. You would have it on for your high-speed handpiece and off for the slow-speed handpiece. Next, you'll see that I'm placing out our bibbies, our instruments. This one so happens to be a basic kit that is closed and sterile, but once we open it is no longer sterile. But we're going to set this out in preparation for our patient. And I like to set these out in the order that we're going to use them too. We'll take our air water syringe tip. We're going to use a metal one that can be sterilized and reused. There are ones that are disposable. Use our thumb to press in that outer metal ring of the syringe and place in the tapered point of that syringe tip. And you've got the two buttons for the air and the water independently, but when you push them together, you're going to get a nice power washer, which is great for rinsing off stuck-on objects. After you have set up your room, you can go get your patient from the reception area, making sure that you follow all of HIPAA protocols. Seat your patient, making sure it's at the proper height Update your patient's medical history and place that bib. And I always get the question, do we have to have our PPEs on at this point? No, we do not. And actually, we don't need to be leaving the room with those on. We're going to take their blood pressure prior to any appointment. And then when it's time to start working, we're going to don our PPEs, our personal protective equipment. I like to put them on from head down. So our eyewear, our mask, making sure that we're putting it on properly, bending it at the nose, placing it over your ears, without looping them. When you loop them, what happens is you actually get like this bunch on the side of it, and pull it down under your chin and fold it around your nose. So you've got your eyewear, your mask, and your gloves last. Now the gloves are really important that you have ones that fit and function, so make sure you're wearing the proper size gloves. If they're too big, then you lose dexterity, and if they're too small, they can rip really easily. So eye, mask, gloves last. We're skipping a few steps here because every procedure is pretty independent on what you need set out for it. And we're going to learn that as we go through the course. And, you know, depending on if it's a recall, which is a hygiene or a dental cleaning appointment, they're not going to need numbed, so we're not going to have to do the topical anesthetic. But let's walk you through some of these common chairside things. Topical anesthetic is used on a cotton-tipped applicator placed in the area of the injection site, which we'll cover when we get into the syringes and anesthetics. But you saw a maxillary placement and a mandibular placement, and I like to leave it in the mouth until the dentist comes back in so they can see that I've already placed it.
So if you want to use high speed and just place it in each quadrant slowly, you can turn towards the
During most of your dental procedures, from crowns to fillings, you are going to utilize the HVE, the high volume evacuator. That's that larger suction. I think of it as like your shop vac. It's going to get lots of water spray. It's going to cut down on the aerosol, any chunks or bits that are going to fall out of that tooth. That is going to be right up against where you are working to help pull those things away. You can use your saliva ejector throughout the procedure too, just to make sure that you're getting any buildup of that moisture out of the patient's mouth so they are more comfortable. As you see here, your doctor is working in the patient's maxillary right, so we will be positioned in the patient's maxillary right, but on the lingual surface. It doesn't matter if the doctor is working on the lingual, you do not cross over to the opposite side of that tooth onto the doctor's side, because you will block their line of sight. Now we are on to those maxillary anteriors and showing two different positions for the HV depending on where the handpiece is placed. If they're working from the lingual and the water spray is coming out of the mouth, then you will want to place the HV on the facial. But if they are working on the facial and the water spray is going into the mouth, you'll place it on the lingual. Notice how we're pulling back that HV and using it as a retraction item to pull back the cheek. We will be on the buccal for the maxillary left. Same with the mandibular or the lower left. We're going to use that to pull back the cheek. Do not cross over to the doctor's side of the tooth, because you are again going to block their line of sight and they're not going to be able to see what they're doing. Now, if the doctor's not in the patient's mouth, that rule really doesn't apply. You can rinse and suction to your heart's desire wherever you need to be. On the patient's mandibular right, this is where you kind of have to work with the patient's tongue, retracting it, pulling out of the way, because you will be positioned on the lingual surface. If you are ever working on the mandibular anteriors, here is a view from us suctioning from the lingual.
Not that you're usually doing. Do you need your puppet? Do you want me to hold
And a lot
it?
of times you're going to have your air water syringe and your HVE in the patient's mouth simultaneously. They do a lot of times come out together. Let's take a different view here, a little bit more up close and personal. We're back on the patient's mandibular right, and if you are ever working with a doctor and they're working on the same side that your suction is meant to be placed on, you can just move a tooth or two more posteriorly, so more towards the back of the mouth, so that all that water spray will be collected in the way that gravity would pull it. We can see the patient's mandibular left. We're using that HVE to pull back the cheek out of the patient's way, out of the doctor's way. Same here on the maxillary left. Key is maintaining a clear field of view for that doctor and keeping the patient comfortable. We don't want to see a lot of fluid building up. That would be really uncomfortable. That's where you can grab that saliva ejector and stick it into the corners of the mouth, being careful not to hit the back of the tongue, the roof of the mouth towards that soft palate, or really just way in the back of the mouth where that uvula would be. We don't want to get that far back. That would be really uncomfortable and can cause our patients to gag and worse, get sick. I don't know about you, but I don't really want to clean that up. Maxillary right, we're on the lingual surfaces here. Some things to note as you watch this again is to make sure that you don't turn on the HV right in the patient's ear, as it can be really loud and startling to a patient. Try to turn it on slowly and away from their ear, and don't leave it sitting running the entirety of the procedure. We're rinsing, we're suctioning as we're going through the patient's mouth here. Next, let's take a look how we would rinse and suction utilizing the saliva ejector, which you're only going to really need if the doctor's not working. The saliva ejector will not be sufficient enough if the doctor's working with the high-speed handpiece. Unlike the HV, they can close their lips around that saliva ejector. Now let's take a look at a slowed-down version of transferring instruments to our doctor. Typically, the mouth mirror and the Explorer will be transferred to the doctor simultaneously, with the mouth mirror going into their non-dominant hand and the Explorer into their dominant hand so they can go into the patient's mouth and start working. When receiving the old instrument, you will grab with your pinky and drop the new instrument down into the doctor's hand in the position of use, meaning if it's a maxillary tooth, have it pointing up, mandibular tooth pointing down, and the end that the doctor has requested. Transferring and placing cottons is something that a dental assistant will do on the daily. When transferring a cotton roll, it's best to transfer it already placed into the cotton pliers. I like to pinch the end that's holding the cotton roll so that they can more easily go into the patient's mouth. Have extra cottons on hand just below the patient's chin in what we call the transfer zone so that the doctor can place for the procedure that they're going to be performing. Here you will see a maxillary cotton roll placement onto the buccal surface of the patient's mouth. Now typically when you're removing this, unless it is saturated with water or saliva, you will want to get it wet so it doesn't stick to the patient's tissues and kind of tug and leave cotton stuck behind. For a mandibular placement, you will place a cotton roll on the buccal surface and the lingual surface just underneath that tongue, being careful not to hurt that soft tissue below it. Notice how the assistant's hand is remaining underneath the chin to receive the instruments that are no longer needed. When the doctor is removing the cottons or any material from the patient's mouth, you'll want to make sure that you have your hands handy so you can receive those items and return them back to the tray behind the patient. Next, we'll see how the dry angle is placed, and they can be placed independently of the cotton rolls or with the cotton rolls for extra isolation of the field that you're working in. The doctor will bend the dry angle, place it into the buccal surface of the patient's cheek, and this is also where it's really important that when it's dry, it likes to stick to the tissue. You want to get it wet so that you don't leave any cotton behind. It doesn't have any discomfort with tugging and pulling of the tissues. At the completion of a lot of procedures, you are going to want to check the bite utilizing articulating paper and Miller forceps, where the patient will chomp chomp, slide around, and it will leave markings on the teeth to determine if any adjustments need to be made. Once finished, you can dismiss your patient, and depending on how your office runs, you may dismiss them and have them walk to the front of the office with a routing slip, or you will bring them up and talk to the front desk about what was completed that day. When breaking down the room, you want to make sure that you transfer all dirty instruments in a non-punctual container to sterilization and place those instruments into your ultrasonic, closing the lid and turning it on, allowing it to process through. Now, because you'll want to leave it in there for about 90 seconds or so, you'll want to take that time to go into your room and wipe everything down, following the instructions of the specific materials that you are using, being careful and mindful to have gloves on while you are cleaning that room. After your room is clean, then you can come back with your dirty gloves or clean gloves, just as long as you have gloves on, removing your instruments from the non-running ultrasonic, allowing any of the extra liquid to drip back into the ultrasonic, and rinsing them off. Your office may have you dry them prior to putting them into a sterilization pouch. Be careful when handling instruments because this is where you can accidentally get stuck. No needles should be transported to your ultrasonic. Needles and any of those sharps should be disposed of in your room into a sharps container. Dump out the instruments carefully into your hand, placing it into the properly sized sterilization pouch. Now, your office may use a different system for bagging or putting them in a cassette, so you want to make sure that you are adaptable and flexible to learn how your office does things. Place it into the pre-opened sleeve. Peel back the sticky tab and fold it over. Now this bag is not sterile. This needs to go into the autoclave and be sterilized. You'll be able to know whether or not this has been sterilized by looking at the packaging and seeing whether or not that the little monitor has changed colors. And you can see here we have different sizes for different purposes. One way that I like to process my burrs is to put them in a tea diffuser. It's a great way to keep them together, but I don't run that through the autoclave. That seems to keep the moisture and they tend to get a little rusted. At the end of your day, what you'll want to make sure that you do is you're draining and cleaning out the ultrasonic. Typically there is a drain plug or a switch that allows that to drain into a sink, and then you will remove any of the cassettes or any items that are in it, scrub it clean because it does get a film, a biofilm on it that we want to make sure that we're cleaning. This can be drained and swapped out anytime that it becomes overly soiled throughout the day. So if you were to put extraction instruments in here and that liquid become overly soiled, then you would want to drain it and put in a new liquid and enzyme tablet. Place your instruments into the autoclave, making sure that you don't touch the front of the door with any kind of dirty gloves because the other staff members may be touching it with ungloved hands. And there's this big debate on whether or not it should be paper or plastic side up. I find that paper side up dries better. The biggest thing is just to make sure that you're not stacking any of the bags on top of each other while you're working because that will prevent it from drying properly. Close and latch the door once it is full, making sure that you do have the water properly filled up. Choose the correct settings, whether it's unwrapped, wrapped, or hand pieces, and let it run. Make sure that when it's completed, you allow it to go through the full dry cycle. And now that you're completely done, if you need to doff your PPEs, make sure that you're doing properly so that you do not contaminate yourself or anything around you. Remove your mask and your gloves, wash your hands and eyewear. Now that we've taken some time to review from last week's information, let's discuss what topics we're going to be covering for this week. We're going to delve into preventative dentistry and the whole purpose behind it, dental burrs, two specialties today, the pedodontics specialty and orthodontics. We'll talk about the Toffelmeyer, syringe, nutrition and how that plays into the overall health, but specifically the dental health of our patient, and charting. What preventative dentistry is are steps that are taken by the patient with the assistance of their dental healthcare team to create healthy oral habits that are going to help them to avoid
dental caries, gum disease, and other dental issues that may be preventable, because about 35% of adults aged 18 and over do not have a dental visit in 2019. And from 2019 to 2020, the percentage of adults aged 16 to 64 who had a dental visit in the past 12 months declined. And that was overall in both men and women. And these visits can be core and vital to the patient's overall dental health. It allows us the opportunity to take diagnostic radiographs, periodontal charting, visual inspections, and inspections of the teeth utilizing instruments such as a Diagnodent or the Dental Explorer. Skipping out on your routine dental appointments can lead to big issues that could have gotten caught way sooner when they're a lot smaller, a lot more manageable, and honestly, a lot more affordable for you to fix too. So while there's a lot that the patient can be doing at home, it's equally important that they're coming in routinely to get the therapeutic scaling of the teeth and then removing stain with the corona polishing part of the appointment. Occasionally in your office, you may have a patient who is not getting an exam the day that they're coming in for a hygiene appointment. It could be because they're a perio maintenance, meaning that they're someone that has in the past had issues with periodontal disease or inflammation of the gums, where they need to come for more routine appointments. And because insurance only covers typically 2 exams a year, they don't want to pay out of pocket, or it's not necessary because we're not concerned about something else in their mouth that needs evaluated. Now, there's some stipulations to this. One, it can't be a new patient. It has to be a patient of record. They have to have had an exam in the past 12 months, and they have to be aware that the dentist isn't coming in for an exam. If all those parameters are met and there's no cause for concern, then it may be that they're simply coming in for their cleanings and then on their merry way after that. The epidemiology of caries, which includes the incidence, distribution, and possibly the control of the disease, does numerous studies showing that about 500 million dental visits a year in the United States occur. And these service costs have increased by 4.2% in 2015 from 2014. That's a $117.5 billion increase. There's a unit of measurement, essentially, the DMF index was used to measure the epidemiology of caries, but I feel like it's simplified the issue. As you can see here, there's so many factors that play into tooth decay. The tooth itself, the amount of time that the tooth has been affected, the diet, the amount of plaque, but even bigger, the knowledge, the education, behaviors, the attitudes, all of these factors play into dental caries themselves. If a person's attitude and knowledge around dental hygiene plays a vital role in the prevention of dental diseases, then it's really important that we do educate our public that dental care actually starts at birth. Because before our teeth erupt, we're still consuming things, and it's good practice to be wiping off the gums of an infant with a clean, wet cloth after each feeding. Things that have fermentable carbohydrates in it, baby food, milks, formulas. Then, as soon as the first tooth appears, which can be typically anywhere from 4 to 6 months of age, we want to make sure that we begin brushing twice a day. It used to be the professional opinion of the ADA that you weren't to use any kind of fluoridated toothpaste until the child was able to spit out on their own. But they have recently changed their opinion and stated that it is fine as long as it is a rice-sized amount. So you don't want to overdo the fluoridated toothpaste because they are going to be ingesting this. So a rice-sized, a grain of rice, imagine that, very small, right? And then up to a pea size when they can actually spit it out themselves. I swear when my kids go in and put toothpaste on their toothbrushes, it's like they're icing a cupcake. I have to buy toothpaste sometimes more often than I would like because kids just don't know. They know that they need to put it on there and they know that it tastes good, so they're going to put a whole bunch on there. Monitor our young children until we are confident that they can brush, floss on their own properly when they need to. I've had parents come in and they're monitoring and even helping their 14-year-old children properly care for their teeth because until they're an adult, really as parents, we should be the ones taking the responsibility and teaching them to have that responsibility for their own health and self-care. Now, I will tell you, taking care of and brushing the teeth of a toddler sometimes is easy. Other times, it's like holding down a greased monkey. Like you're wrapping your legs around them, you're wrapping your arms around them, just so you can get that toothbrush in their mouth safely. But don't give up, because it is worth it. As tempting as it might be to put our sweet little babes into bed with a nice bottle of milk, we really shouldn't, because the sugars that are in our drinks, even from our milk or apple juices, can sit on the teeth overnight and cause what we call baby bottle tooth decay. If you've looked at pictures of it, honestly, it kind of resembles meth mouth in the sense that there's rampant caries, unchecked caries all over the place because of those liquids sitting on their teeth all night long. If you want to send your little one to bed with a bottle, put some water in there. Depending on the child's maturity level, we really want to see that kid by age 3. That first appointment may just be as simple as the kid sitting in the dental chair, riding it up and down, looking at the mouth mirror, letting us look in their mouth. We may not get a prophy cup in there because it may be overwhelming to them. It's scary. It's different. If you think about children, how they aren't, because mutant streptococcus, which is what causes dental caries, is not present in a newborn's mouth, we want to be cautious to not put anything in the baby's mouth that has been in yours. Fully develop, their frontal lobe doesn't develop completely until about age 20 to 21, a little kid isn't going to be able to rationalize that the mask and the gloves and the eyewear and the bright lights and all the sounds aren't something to be feared. I mean, think about it. How many adults sit in our chair and they have dental anxiety? Well, a lot of that can actually be stemmed back to negative experiences that they had as a child. We're building that foundation for them. So those early appointments can simply just be them having a good time sitting in the chair, letting us count their teeth, and getting a prize out of the prize chest. Eventually, we are going to be able to get in there to clean their teeth, maybe scale their teeth, take x-rays when they're old enough, put fluoride on, all the things that we need to do. But we want to take our time and build that good rapport with the child. I always encourage parents, if the kid is going to cooperate, obviously we don't want kids running through the office for safety reasons, but bring them to your dental appointments. That way they become better acclimated to the dental office and they get to see you sitting in the chair, not scared that this is fun and this is enjoyable. Let them hop up in the chair after you're done so they can see there's nothing to be afraid of. The sooner that we can detect decay, the better, because dental caries is actually considered a childhood epidemic. It affects about 1/3 of all preschool age children. Going to the dentist routinely every 6 months for that exam, using that Explorer, taking radiographs, but also using things like the Diagnodent. This is a safe fluorescent laser that helps to detect hidden tooth decay quickly and in its earliest stages. The Diagnodent uses a precise laser system, and what it does is it scans onto your teeth while sending out an audio signature and registering a digital readout. Basically, what it does is it gives back a number where we can determine how much of that has been absorbed by the tooth. This keeps us from having to scratch at, probe at, or open up the tooth to detect whether or not it is dental caries or not. Now, I have a funny story about this. We had in our office a cookie oven, just a tiny little thing up at the front desk that we would give our patients cookies when they left. I know, that sounds super counterintuitive, but I told you, us dental people typically have a sweet tooth, and as long as you're not eating those all the time and you're brushing and flossing afterwards, you're typically okay. So we had that, and we would give them those chocolate chip, those warm, ooey gooey Otis Spunkmeyer cookies. Oh my gosh, I can smell them now. But we'd give those to them after their appointment, and they'd be on their merry way. Well, our front desk staff thought that it would be a better idea one day to give the children their cookies while they waited for their appointment. And so when the patient sat in the chair, I think it was like a 6-year-old or something, sat down in the chair and the hygienist is getting ready to look in and just see how everything looks. When they opened up that split second, not expecting it, all the chocolate chips were wedged down into every single groove. It looked like this poor patient was just riddled with dental caries on every single surface. It was, again, that split second you look in, you're not anticipating that. She didn't know that they were given cookies ahead of time, and she wasn't super thrilled that now she had all of this chocolate chip to clean out. And let's just say that didn't happen again. And thankfully that patient didn't have any dental caries. You're going to have patients with all kinds of different personal opinions when it comes to how often they should be coming to get their teeth cleaned, whether or not they should be getting the prophylaxis like the coronal polishing. Now keep in mind the coronal polish is not the therapeutic part of the appointment. It's the actual scaling and removing of the hardened calculus off of the teeth. That's what's going to really keep your mouth healthy. The pumice, that polishing paste, that simply is used to remove stains, smooth out the tooth. It is more of an aesthetic thing for the appointment than therapeutic. Some patients don't want you to scale, although again, that's kind of the big part of the appointment. Patients don't want fluoride. If you look up fluoride, there are so many opinions from one side to the next. There's this broad spectrum of whether it's really good for you or really bad for you, or some people are just kind of in the middle and don't care either way. As the dental profession, we are proponents of fluoride. And so even though our patient may be strongly objecting it, we need to honor the fact that that's their wishes. They get to choose whether or not they want fluoride on their mouth and their child's teeth. And what we can do is we can, offer up some educational material, but try not to be offensive. Don't make a patient feel, bad about personal opinions and beliefs on whether or not they should be getting their teeth scaled or how often they should be coming or whether or not fluoridated toothpaste or fluoride varnishes are good for them or not. That, we do our best to educate the patient on what us as an office stand for and try to leave our own personal opinions out of it. We want to remain a professional no matter what it is. And you'll get that with x-rays. You'll have patients that just almost always refuse x-rays, but honestly, we are underserving that patient if we don't take x-rays often enough. We don't want to overtake them. We don't want to overexpose our patients because it is radiation. There are risks associated with it, even though it is, medically necessary for us to detect dental caries and other disorders of the mouth. You might have a patient who's very leery of it because maybe they have a past history of cancer or they've already undergone radiotherapy and they don't want to overexpose their body even more. Every patient has to be looked at as an individual. When they sit down, we don't want to be in too much of a routine that we gloss over looking for these dental caries and utilizing all the things that we have at our disposal. If your office has a Diagnodent, why aren't we using that on our patients every single time that we think that there might be a change in the tooth structure, just to wear out whether or not it is, decay or demineralization or just discoloration of the tooth. We do have some ways also to kind of determine whether or not a patient is at somewhat of a higher risk of dental caries. Even if they don't have them now, we can kind of know whether or not this patient might be at a risk for it later on. The ADA's caries risk assessment forms were developed as tools for dentists to evaluate a patient's risk of developing caries. This doesn't mean that you're a guarantee because you are in the high risk category. It's just helping us to better keep an eye on our patients and educate them individually. One form is for the patients ages 0 to 6, and then another one is for patients over the age of 6. These can be used as communication tools with the patient or the patient's guardian to help highlight potential risk factors such as fluoridation lacking in their water or improper oral hygiene. Maybe there's a genetic factor that we're noticing that their siblings and their parents have a high rate of decay, or their diet. They're saying that they're ingesting those sugary drinks, sugary foods, fermentable carbohydrates on the regular. Those are all reasons that we would want to do this so we can bring this to the attention of the patient and the patient's caregiver. Now, these are not at all inclusive forms, so they're not intended to include all possible risk factors. The risk factors selected are intended to provide the patient with information that might help them lower the risk over time, while also providing this, it can be integrated into a busy practice setting. So you don't have to do this in the chair. You can send this home with your patients. You can have it a part of their check-in process where they're filling this out as new patients, asking them to evaluate their fluoride exposure, sugary food intake, immediate family caries, healthcare at home, their dental health, general health concerns. And what they'll do is they'll mark low, moderate, and high. When you are low risk for caries, that means you only have conditions in the low risk column. Now, when you are marking anything in low and moderate, then you are considered moderate risk. But when you are marking one or more conditions in the high risk column, then we consider that patient a high risk for dental caries. And that's when we're going to strike up those conversations and educate our patient in a considerate, compassionate way for them to understand. As we're evaluating the patient's dental caries risk, and we're also evaluating whether there are dental caries present, if we were to just limit our examination to cavitated lesions by using the GB Black system, we fail to actually recognize the earliest signs of dental caries and underestimate the prevalence and severity of the disease. So, as stated in the Journal of the American Dental Association 2015 article by Dr. Young, Novi, Zeller, Hale, Hart, and Truelove. A clinically sound tooth is going to have no surface change. It's adequately restored. There's no radiolucency on a radiograph. The initial stage is when you have that really early clinically detectable lesion. This is a frank lesion where it's not cavitated, but you might see some change in the coloration. When you dry the tooth, that's where you're going to see white, brown. The enamel has lost its glossiness, and you may even see some radiolucency that goes into the dentoenamel junction of the tooth. Letting that disease progress, it's not going to stop on its own. We move into the moderate category where there are visible signs of the enamel breakdown. Dentin is demineralized, and we start getting that early cavitation with small, shallow pits, with the radiolucency extending into the middle 1/3 of the dentin. And finally, we end up in the advanced category, and this is where we've let the disease progress. This does not happen overnight. Someone doesn't just wake up and have a cavity. It takes time. This is where the enamel is fully cavitated, the dentin is exposed, there's probably a lot of pain to hot and cold, pressure, and it's going to spread from tooth to tooth. This radiolucency goes into the inner 1/3 of the dentin. Now, when I'm talking about radiolucency, if you're looking at these x-rays of the teeth, do you notice how from the far left clinically sound tooth to the far right advanced, you see that gray kind of funnel-shaped projection on the inside of the tooth? I know it probably is a little challenging to read the radiograph because we're not covering that till week 6, but hopefully you can see that there's a difference between the two x-rays. Radiolucency, where you see it darker, is where there's a less dense area. This is the area of the tooth that's being destroyed by the dental caries. What it's getting closer to in that far right advanced image is it's getting closer to that pulp cavity, that dark inner portion. Yes, it's less dense than, say, the enamel and the dentin, but that infection, that bacteria is going to get into that, potentially that pulp. And once we have that, now we're looking at this tooth as potentially either a root canal, endodontic therapy, or an extraction. We want to catch these earlier on. So using tools like the Diagnodent. DEXIS has this really unique item that uses infrared light, and it passes through the tooth so that we can look at it instead of from the side like in these x-rays. We're looking at it from like the occlusal surface to try and detect caries that maybe would go unseen because of the way that they're positioned on the tooth, or that they're really early stages that the x-ray is not able to pick up at that point. Not every dental carie, not every time a tooth gets a cavity is that it's 100% preventable. I like to think that I've done a pretty good job with my own oral hygiene. I am super hyper focused on my teeth and brushing and flossing and going to the dentist, but I've still had cavities. It could be genetics. It could be maybe not enough fluoride because we have well water and we don't have fluoride in our well water. The ADA's CCS, Caries Classification System, actually attempts to correct these limitations. They include criteria for detecting early lesions and for monitoring these clinical statuses, with the hopes that it will facilitate the measuring of effectiveness of contemporary management strategies. It could be because of previous pregnancies and how that affects the oral health too. It's really hard to say and limit it down to an exact cause, and that's where that caries assessment just gives us a general idea. It's not saying, okay, because of XYZ, this is why you have dental caries, because there are people that take excellent care of their teeth, but they end up with periodontal disease. They end up with dental caries, and there is that strong genetic factor. There's other medical conditions that play into it, other medications that they're taking. There are a lot of in-office preventative things that we can do to try and help prevent these dental caries from occurring.
There's a great amount of ways for someone to practice preventative dental care. One of the great ways that are available to a patient is coming in for their 6-month recalls, where a hygienist or even an assistant who's qualified will utilize a Prophy angle with the Prophy paste to remove the stain and therapeutic scaling of the teeth. Another way is the utilization of fluoride. Now, it can be utilized through topical applications in office, like a fluoride varnish, where the assistant will mix up the fluoride
and paint it directly onto all surfaces of the teeth. So this is going to be facial, lingual, buccal, even the occlusals. Coat all of those surfaces, being careful not to get it on the lips as it's really sticky. But if you do, hot water will help get that off of there. No eating or drinking is no longer needed to be practiced because the varnish will actually adhere to the tooth. Now, they have to make sure that they're not eating or drinking something hot as in temperature-wise because that can take it off, or things like apples that might scrape it off too. Coming routinely to the office will allow us to not only scale, polish, and put fluoride on the patient's teeth, but we can also take this time to educate our patient. A great educational item is going to be disclosing agents that come in a liquid or a tablet where the patient simply chews it up, swishes around, and you can suction it or spit it into a cup. And then what you'll do is show the patient anywhere that there is a dark area, typically interproximally or along the gum line, that's where they need to brush and floss better.
Since the 1930s, the American Dental Association has been implementing what they call their Seal of Acceptance. This is a voluntary program where the manufacturers choose to submit data to the ADA Council on Scientific Affairs and are awarded this seal. This is something above and beyond any FDA approvals that they have to be on the shelf. They have to apply or reapply every 5 years, meaning that it's not something that they get once and then they kind of aren't checked in on anymore. They have to continually submit research and data to the ADA to maintain that. So if you see the ADA seal of approval on a dental product, generally you can feel pretty good about that product because they've gone above and beyond what they legally have to do. In 1956, Crest released their toothpaste Fluoristan, which received the ADA seal approval. And clinical studies submitted found that on average there was a 49% reduction in cavities ages 6 to 16. So since the 1950s, dentists have employed fluoride to help combat those early childhood caries. Now, fluoride, just like anything or fluorosis of the teeth, you're going to get fluoride through systemic and topical avenues. Systemic means it's naturally occurring in food and water, and you're ingesting it. It's getting broken down by the body, and it's being sent out through the body where it needs to be. Or you can apply it directly to the teeth through a topical application like a mouthwash, varnishes, toothpaste. And the goal of the fluoride is to remineralize, not repair. There is some misconceptions, I think, with some of the public that they think that fluoride is going to take a tooth that has obvious signs of cavitation, so it has dental caries, and that if they rinse enough with the fluoride that it's going to eliminate that dental caries. But that's not how it works. It's like rust on a quarter panel of a car, that if you spray paint over it might look better, but it's not going to stop it from spreading. Same thing with this, like you can't, just do better with your oral hygiene and expect what the damage is already there to just stop. It will continue, it will spread, it will get worse. So they do have to go into more restorative procedures. They go from preventative dentistry now into restorative dentistry. But there are still other things that a patient can have done in office to try and help protect their teeth sooner rather than later so that they don't end up with dental caries. Good. You can't have too much of it. Having too much fluoride can be harmful for your teeth, and you can end up with fluoridation. In 1950, Procter & Gamble and Dr. Joseph Mueller at Indiana University began developing and testing a new dentifrice. There are lots of ways that us as the dental professional can help patients protect their teeth against dental caries. There's certain studies that have found that there's been an overall decrease in the number of caries in children over age 5. But there has been an increase in caries prevalence in ages 2 to 5. Any idea why? Well, it could be lack of access to dental care because they don't have dental insurance, more access to sugary foods and drinks. Could be that they just don't know that that young of a mouth does need their teeth brushed, does need to go to the dentist and have these things taken care of. One time we took a class to a local elementary school and we presented oral hygiene in a really fun way. We brought puppets and poster boards and games to these kindergarten and first graders. And one of the posters was split in two. One column were foods that were good for your teeth, and the other column were foods that weren't so good for your teeth. And we had little pictures of the different foods, and they had to put them on which side they thought they belonged in. And you would be, and maybe not be, surprised that a lot of these kids were surprised themselves to find out that pop, chips, candy, those sorts of things really aren't good for their teeth. And we know, obviously, overall health too. Now, I'm not saying, again, in moderation, that these things are the end of the world, because just like most people, I like to indulge in those things. I like some Oreos now and then. But if I sat and ate Oreos all day long, it's going to affect my overall health. Probably going to have some issues with my heart. But also, it's going to directly affect my teeth because that sugar's sitting on my teeth all the time. That's not overly surprising if someone has a restricted budget on what they can spend on things, and you've got this healthier product at $7 and this unhealthy product at $2. Well, that's a big price difference there. There could be lack of knowledge of importance of dental care in the pediatric mouth. There's so many possible reasons as to why there's an increase in that age point. You might have had this performed to your teeth as a child, or maybe you have little ones yourself that the dentist has proposed that they want sealants. Sealants, the idea of a sealant is that the tooth naturally has grooves that food and bacteria can get down into, and the bristles just don't do a perfect enough job to clean out those pits. So in 1923, a dentist suggested prophylactic odontomy, where what they would do is they would take a burr and they would drill down into those grooves and widen them. The idea is then the teeth can be more easily cleaned out with a bristle because they're not these little tight grooves. It allows for the teeth to have laser caries. Obviously, they didn't have that in 1923, but now it would allow us to detect caries a lot easier utilizing that Diagnodent, which with having sealants, sometimes you can't do that. So the idea is odontomy is in place of the sealant. Like you're widening those so you can clean them out easily on the teeth. Now, we did see that early on, occlusal surfaces were more vulnerable because fluoride is effective on smooth surfaces. So it's not the most effective in the grooves of the teeth. And of all the surfaces of the teeth, your occlusal surface accounts for a big portion of that tooth. That's 12.5% of the tooth. And those caries cases, which account for 86 to 91% of school-age kids, had occlusal surface cavities.
Setting up for a sealant procedure is one of the more basic procedures and involves very minimal instruments and very minimal items that you need to set up. You will need your mouth mirror, your Explorer, your cotton pliers, acid etch with a new tip, which these tips are disposable for every patient, so you will untwist, throw away the tip, wipe down the tube and put a new tip on after each patient. Same for your sealant. Miller forceps with articulating paper. Floss so that you can check interproximals to ensure that you didn't get floss in those. Pumice. Your straight nose cone with your Prophy cup, which all attach to the slow speed motor. Cotton rolls, triangles, 2x2s to help isolate the tooth and keep it nice and dry. Your high speed and slow speed should be kind of handy in case you need to remove filled sealant material. Your curing light and any appropriate PPEs. Prior to a sealant procedure, you're going to have your doctor examine the tooth to ensure that there isn't any decay. Should there be signs of decalcification or a frank lesion, decay, then the tooth would not be eligible for a sealant to be performed. They would then have to move into a more restorative procedure. Typically, we like to combine a sealant procedure with the same day that they're getting their dental cleaning, just to make use of everyone's time. We're going to start off by checking for decay. Whenever we hand our instruments over to the doctor, we're going to make sure that we hand it to them in the position of use. So if we're working on a mandibular tooth, your Explorer, your mouth ring, and any other items that you give them should be positioned so that they go right in and are able to use them. Should we be working with a right-handed dominant doctor, then the Explorer goes into their right hand and the mouth mirror into their left hand. They then will march around the tooth, checking for signs of decalcification or decay, and give the go-ahead if they are good. If this is immediately following the dental cleaning, then what's really beneficial is that they've already had this step completed, which is the pumice with the Prophy paste on the straight nose cone attached to a slow speed motor that you then can press down on the rheostat and use. Now, if you're a dental assistant without your coronal polish license, then this is a step that you are not allowed to do. Even if you have been trained on the sealants and can do that after you've been certified and take the course, the coronal polish is an additional course. So they will polish the teeth, removing the plaque off of these occlusal surfaces. After that's been rinsed clean, then we can start by isolating the tooth. Handing your doctor cotton rolls can be done either with just your bare hands or with cotton pliers so that they can grab and use them. We will place one under the lingual area, so under the tongue. We're also going to place one on the buccal surface. Next, we're going to hand them the etchant underneath the chin in the position of use so that the doctor may grab and start working. We always want to anticipate their needs, so understanding your procedure from start to finish is going to allow you to be able to have the next step ready and waiting. The etchant is going to be syringed onto the occlusal surfaces and any of the other pits and fissures that are going to be filled, so maybe there's a little bit on the buccal or on the lingual. And it's going to sit there for 30 seconds. And what this is doing is it's removing the smear layer. After that's sat for 30 seconds, then you are going to rinse and dry for 30 seconds. You're going to take your HV and place it right against the tooth to help prevent them from getting this acid etch on their tongue. It's a really bitter taste. We're going to take our air water syringe and we're going to place our thumb on both the water and the air button simultaneously to get our power washer. When your doctor requests that you dry the tooth, they're not saying take your suction to the tooth. They're saying take the air of your little mini hair dryer and dry that tooth thoroughly. At this point, you may want to switch out your cotton rolls for ones that are not wet, because we really need this tooth to stay completely isolated and dry. At which point you may choose to use the Dri-Angles. The Dri-Angles, which are triangular pieces of cotton, we kind of get them loosened up, placed into the cheek to help soak up the saliva on the buccal surface, with this tapered in going towards the back of the mouth. Next, what we can do is grab our sealant. We're still going to give it to the doctor under the patient's chin in the position of use so they can grab and start using. When it comes to sealants, less is more, so you really don't need a lot. They're going to use just a pinpoint amount of it. And I can anticipate their needs and have the Explorer ready and waiting, where they then will take their Explorer and start moving that sealant down into all the grooves that we want to protect against decay. Once they are satisfied with the placement of the sealant, then we will cure it with the curing light. P for R's turns the power on. M for mode will change the setting that you have on it. You can hover it over the tooth, but don't touch the tooth, and we're going to cure for 20 seconds. You can safely look at the light through the orange shield without being concerned of it damaging your eyes, but try to avoid looking at the light while it's working. The doctor then will check to ensure things are fully cured, there's no voids. If there are voids, now is the best time to add a little bit more sealant. This way, they don't have to worry about keeping that tooth dry. It's already being maintained, that isolated area. Once you've done one sealant with your doctor, you've done basically all of them because it's repetitive. Throughout this procedure, if the patient's mouth begins to fill with saliva, then what you'll want to do is grab your saliva ejector and go to the corners of the mouth and do a quick suction. Always ensuring you don't accidentally rinse the sealant. You don't want to use any water or rinse after the etch step has been dried. Once it is cured, it doesn't matter that it gets wet, other than if you wanted to add more sealant, then we'd have to go and re-etch the surface. But if we're happy and satisfied with this result, and we want to check the bite and the interproximals, the best way to remove your cotton rolls in your Dri-Angle is to pre-moisten the cotton roll, pre-moisten the Dri-Angle, and it makes it easier for you to remove it from the patient's mouth. Next, what your doctor will do is they'll take their Miller forceps and articulating paper that, to get it placed in, you squeeze, put it in long ways, and it looks like a little flag. You're gonna hand it to the doctor so that when the patient bites together, this metal part is on the outside of the tooth, so you don't want them putting it in and ending up biting down like this. But as they chomp and slide side to side, what essentially they're going to be doing is leaving these little trace marks. And as they're doing that, what you want to be looking for is, are there any blue marks on the sealant? And actually, there's a little bit right there on that sealant. The cusp touch, that's normal. It's if you see these little blue halos that we know that that sealant's too high. If you're using an unfilled sealant material, which means that it doesn't have silica or glass components to it, then this will normally wear on its own. But if we're using a filled sealant material, then what your doctor would have to do is go in with either their high speed or with their slow speed and in a burr
typically a round carbide, and remove that excess sealant material. That way it doesn't cause abnormal wear and damage the tooth itself. They'll also take their floss to ensure that nothing got down into the inner proximals. And then the patient is done.
There are options for types of sealant materials, including ones that are auto-cured or light-cured, and auto-cured is going to be cheaper, but they give you less working time with the material. You also have the option of a filled or unfilled sealant material, which are both equally effective, but a filled sealant that is going to have the glass, quartz, and other fillers are going to help with the longevity of the sealant. So it's going to be stronger, it's going to last longer. But the downfall of using filled is, say you accidentally add too much to it, you have to check that bite. Unlike unfilled sealants that don't have those other additives, the natural grinding of the teeth is going to wear them down if there's any high points. So you have to check for occlusion using the articulating paper. I like to do that with any of the materials anyways, but with the filled sealant, you then have to adjust the bite with, say, a slow speed, leaving us with some pros and cons to each of the materials. So it will definitely be just preference of the doctor. When it comes to any dental materials, the way that I've always thought of it is walking down the shampoo aisle. All of the shampoos clean your hair, but maybe one is better for curly hair, one is better for colored hair, or you like this one because it is this type of product and your friend likes a different one. They all get the same job done, but maybe in different ways. And that's where being flexible and adaptable as a dental assistant is equally important, because just because we do it one way in our office and you go into your first office and they do it a little different doesn't mean that you were taught wrong, and it doesn't mean that they're doing it wrong. It just means that they're doing it differently. Have you guys ever gone to one of those like paint your own canvas things where everyone's following along with an instructor and they're painting the same subject, but somehow everybody's painting turns out just that much more different? It's because of the artistic part of us that we're going to create what our imagination visualizes. So, using materials that we like, that we prefer, that are, we think are better for those, but also maybe there's a cost factor that plays into what your dentist is choosing. So unless they're breaking a law, doing something unsafe, be flexible. Learn as much as you can from every different practitioner you ever work under. Because again, just because they do it differently doesn't mean you were taught wrong, doesn't mean that they're doing it wrong. It's just a new way to do it. And as you saw in the video, the acid etch is a vital step in placing sealants so that it would better adhere and stick to the tooth, because it's going to create what we call enamel tags. It essentially roughens up the surface of the tooth using that 37% orthophosphoric acid for anywhere from 30 to 60 seconds to remove a small amount of the enamel. You're going to see that it's kind of chalky white before you put that sealant onto the tooth. According to the ADA, BPA is widely used in the production of plastics and resins, and while it is not directly used in the manufacture of dental materials, it is used during the synthesis of certain things. And that's a little beyond what we're going to delve into. But your patients have access to the internet. They're looking up different articles. They're reading things about BPA leaching from dental materials. Be prepared for those one-off patients that are going to ask questions, they're going to have concerns, and if they're not something you can confidently and legally answer, go grab your doctor, let them know. The general public's concern with BPAs in the materials could be caused due to studies on columbia.edu that link exposure to it to the development of ADHD, obesity, and heart disease. The Mayo Clinic, I looked it up, states that additional research suggests a possible link between BPA and increased blood pressure, type 2 diabetes, and cardiovascular disease. However, the U.S. Food and Drug Administration has said that BPA is safe at the very low levels that occur in some foods. We're not delving into this. We're not getting on this hot button topic, but this is one of those things that your patient might bring up, and this is where we do have to tiptoe on our personal thoughts and opinions on things and what your office's stance is. So if you don't know the answer, go grab your doctor. And thankfully, there are plenty of BPA-free dental sealant materials available, so we don't usually have to have those in our office, so then our patients can feel confident in the safety of the materials being placed intraorally. We do want to keep safety data sheets, which are SDS sheets, previously called MSDS sheets, material safety data sheets. They've just dropped the M. We should be keeping that in a binder, typically your OSHA binder, on any materials that we have in the office, so we can quickly flip open to it if a patient has concerns. There are a lot of changes and back and forth and different things that have been developed throughout the years in dentistry, and Dr. Michael Bronicore, known as the pioneer of adhesive dentistry, experimented and developed a method for our resins, like our composites and those sorts of things, and sealants, to stick to enamel and dentin. This is known as acid etch. His acid etch technique allowed that bond to happen between the tooth and the enamel surface. He then went on to develop resins that utilized quartz glass into the base, which would help to solve a lot of issues when it came to adhesion in dentistry. So basically, they would put sealants on teeth, they would put composite fillings on teeth, and they would quickly fall out because they weren't bonding to the tooth as it should be. And so the acid etch technique really was a game changer for that. Also, around this time, there's a lot of research backing adding fluoride into the public water to help with the overall problem of the general public having dental caries. This is where we're going to start switching things up a little bit. We focused a lot on professionalism, preventative dentistry. Now we're going to delve a little bit into restorative dentistry when we talk about dental burrs, our specialties like pediatrics and orthodontics in the coming parts of our video. At the completion of this week's virtual training, you really should start feeling a lot more confident in the materials as we're going. You're getting into a groove of how things work. A dental burr is an attachment that's inserted into either your high speed or your slow speed.
Now, to identify the burr, it also helps us to be able to identify which handpiece that burr is designed to go into. So this should be reviewed. The shank end, or the end that actually is inserted into the handpiece itself, this is what determines what handpiece it fits into. The larger in diameter and in length burrs are going to be your lab shanks, and they go into your straight nose cone. So that would be your acrylic burrs, quite a few of those mandrels, and those different, and prophy cups even, but those aren't considered burrs. The second one that we have pictured here, that's a latch type, and that only goes into your slow speed handpiece. The slow speed handpiece, think of it like a key. When you turn a door, or you turn a key to get into a door, you have to line up all these spots for it to work, and that's how that slow speed burr works. You have to kind of twist it into there. The friction grip, which is smooth, that goes only into your high speed handpiece. On the ends here, you'll notice that there are what I'll say are dummy heads. These don't have any real purpose. These are just stand-in, fillers for right now. All we're focused in on is what's in this maroon box currently. We're going to start with the enamel cutting burrs, which are specifically designed for cavity preparations where we prepare the tooth and remove the decay. The straight fissures, if you think of it, they're straight like the barrel of a gun. They're straight up and down. My lines aren't perfectly straight here, but that you kind of get the point there. It's straight up and down. But the plain cut versus the cross cut describes the cutting surfaces. A plain cut has their one set of vertical cuts, whereas a cross cut has their vertical cuts along with their horizontal cuts, hence the name cross cut. So straight fissure describes the shape, plain cut versus cross cut describes the cutting surface there. Let's take a look at another burr that's very similar. Here we have the tapered Fisher plain cut, which looks just like the plain cut with the straight, except it tapers off, same with the cross cut. So remember, plain cut and cross cut describe the cutting surface. Straight versus tapered describes, is it straight up and down, is it parallel along the sides, or does it taper off? These burrs will have names. They'll also have associated numbers with them too. This next grouping of burrs are diamond burrs. They come from extra fine all the way to extra coarse, kind of like your sandpaper does. These are typically used in your crown preparation appointments, and their names really describe what they look like. So a diamond flame kind of looks like a flame coming out of a lighter. A tapered flat end, and a football diamond, well, it resembles a football. Rubber points come in a lot of variations. They might be lab burrs, or they might be latch type for your slow speed. As you can see, there's variations to even their heads, but they are designed to polish restoration. So at the end of a composite filling, we want to polish it up, make it nice and shiny and smooth, or polish a denture or a night guard. That's when we'd utilize this burr. Now what we're looking at is a perfect example showing the difference between the head of a burr, which is the actual functioning cutting portion, and the shank of the burr, which is what inserts or connects it to the hand piece. Both of these pictured are round carbides used to remove decay. Those are what are circled in the blue circles there. But they each have a different shank in those red squares. The one on the left is a friction grip shank, which will only work in a high-speed handpiece, whereas the one on the right is a latch type shank, and it would only work in the slow speed. If you try to put it in a different handpiece, it wouldn't actually work. So you'll know clinically whether or not you're doing something wrong. But as we're learning to identify them, split them in half, almost cover the head and first identify the shank. And then cover the shank and identify the head. It's almost like when you were kids and you had those flip books that, it's like, okay, you got the head of an elephant and the feet of an alligator. You kind of switch around those different parts. Think of it that way. You are covering the head and interchanging the shank there. Here's another example of a burr that has two different shanks pictured. The one on the left has a latch type that goes into a slow speed handpiece. And the one on the right, although it's hard to tell because they're not proportional to each other, this is a lab shank. So it would only go into your straight nose cone, the same one that your Profi cup went into with your sealant tray. Now the mandrel itself holds sandpaper disc, which help to sand and smooth and file down chipped teeth or restorations to make them not so rough or gritty. Now a pop-on mandrel versus a screw-on mandrel, a pop-on mandrel, the sandpaper disc is, well, popped onto it. And then the screw-on mandrel, you screw the sandpaper disc into place. The inverted cone and the pear-shaped cone both have the same function to create what's called an undercut. When we get into, specifically our silver amalgam fillings later in the course, we'll see why this is important for that particular bonding. But an undercut essentially is a ledge or a lip in the cavity preparation that will allow the filling to more effectively hold on to and grip onto the tooth. Inverted cones create more of that distinct boxy, direct edges, whereas the pear shape is more rounded, and you can kind of tell that where it gets its name from, the bottom of a pear is more rounded in that sense. Our last, the burrs that we're going to learn, keeping in mind there are lots of burrs and every doctor has their preference, so you'll learn the ones that your doctor likes and when they use them, is the football carbide and the acrylic burr. Now really they are not the same burr and they're distinctly different in their sizes. These are not proportionate by no means. The football carbide is much, much, much smaller than an acrylic burr. But they are both used to adjust restorations. The football carbide is used intraoral or inside the mouth to adjust a restoration like a filling, whereas an acrylic burr is used extraorally or outside of the mouth to adjust dentures and night guards, orthodontic appliances, and things that you would adjust more in that lab type setting. So make sure that you're studying these burrs, particularly on Quizlet. That's going to be your best way of learning and being able to identify them on site.
Additionally to the burrs that are going to be on your midterm assessment is the clinical assessment on the ability to set up a Tafelmeyer. This will also be a part of restorative dentistry. We're using it anytime that we're doing an interproximal restoration. The video that's going to follow is going to walk you through this skill, just like any other skill that you're going to be trained on virtually throughout the next several weeks. You're not expected to know exactly how to do it when you walk in. These are ones that are going to get your feet wet so that when you do come to clinicals, you can jump right into the station, practice it, ask questions, and it won't be completely new to you.
Whenever you're working with a posterior class 2 restoration, which is something that involves the interproximal surfaces, so those are those mesial and distal surfaces that are down in between the teeth, we need to utilize something called a matrix system. The matrix system is designed to create a temporary interproximal wall, so something that separates that interproximal surface of the tooth that is diseased from the tooth adjacent to it. So as you're placing that filling, it doesn't end up sticking to the tooth next to it or bonding to the tooth next to it and creating one really large tooth. So the posterior matrix system that's most commonly used is the Toffelmeier matrix retainer or matrix system. This mechanical device actually holds the matrix band, which are these little silver boomerangs, into place, creating that temporary interproximal wall. There are different types of bands that are available. So the bottom one that is smooth is going to be our universal band, whereas the top one that has those extra little winged protections are what we call the extension band. So these are typically used when you are working with a really deep restoration that can extend below the gum lines. They come in different gauges, so essentially are they considered soft or rigid or hard, is how flexible is that metal. So this one's pretty soft and flexible, whereas this one is a slightly bit more dense material, so it's got a little less play to it, so it doesn't crease as easily and it stays in place a little bit more firmly. Prior to the band being placed on the tooth, what a lot of dentists and EFTAs prefer to do is to take an instrument like a burnisher and to rub it along the sides of the band to create a more contoured shape, more natural to the anatomy of the tooth. As an assistant, without being trained as an EFTA, we are simply setting up this Toffelmeier prior to the appointment beginning. So you're not actually putting this on the mouth, which later we'll see what that looks like inside the mouth, but we are setting it up when we look at the schedule and we see tooth number 30 has an MO, tooth number 20 has a DO, so then we know that they're going to need some sort of a posterior matrix system. The retainers also come in some variations. So we've got ones that are specific for the mandible. You'll see that it kind of has that angled part. And then we have our one that we're going to use in class that's more of that universal. Now there are different parts of this Toffelmeier that we want to kind of talk through here so we understand when I'm using this terminology, what exactly am I talking about? When we talk about the knobs, we're talking about these two on this end. The smaller knob is what screws the spindle, so the screw-like structure, and pinches the band into place so it won't fall out. The large knob, as you twist it, you'll notice that it moves the box, we call that the vise, up and down the spindle, which then in turn changes the diameter of the band. Obviously, then this is called the vise, and in the vise, there's a little horizontal slit that goes through it, and that's where the tail ends of your bands will go. And on this end, we have these sets of prongs. We have one set, and we have our second set. And you'll notice that it kind of has a U shape to it. Anytime that we're setting this up, whether it's for the upper, lower, right, or left, you're going to want to make sure that that U is facing up towards the sky. So this is what you should see whenever you're setting up the Toffelmeier. You should also have your band always shaped like a V. So we don't want to see a tint, because what happens is if you take these tail ends, which is this end and this end, and you close them together to create an uncreased loop, like so, you'll notice that on one end of that loop, it's a little bit smaller in diameter than this end. You can kind of see it funneling up. That funnel needs to be directed towards the gum line, and so does these prongs. So when you're holding this up,
like a U, that's for the upper arch, and when you're holding it down like an N, that's for the lower arch. What that's going to ensure then is that the smaller end of that loop, this end here, that's the end that's going to go towards the gum line. If you think about the shape and anatomy of a tooth, as we get towards that gingival third, which is the gum line area of the tooth, it does get a little bit smaller in diameter. And so this creates that natural shape of the tooth. We take our uncreased loop without flipping it and turning it as we go. So always making sure that if we open it, it still looks like a V. We touch tail end to tail end. We're gonna take those tails and we're gonna slide it right down into the horizontal slit and allow it to go straight through. Now, if for some reason it doesn't want to go all the way down, what probably is occurring is that the spindle, so the screw, is in the way. So it's all the way up inside the vise and it's just not allowing it. So mess with the small knob, and then it should slide down without any interruptions. But we don't want to leave it like this because right now it's really loose, it could pop off and it's not going to be useful. So if you want to tighten that band into place so it won't pop out, you'd use the small knob. But before we do that, let's determine where this band actually needs to be directed, because right now it's not going to be useful for any particular region in the mouth. So if I'm working in the upper right hand quadrant, so that's tooth numbers 1 really through 5, we don't use this on an anterior tooth, we're going to take this band, we're going to keep our thumb on this little horizontal slit so it doesn't pop out. I'm going to take my band out of not the first set but the second set of prongs and use those as directional prongs that will turn it to the right side. So upper right to the right. Upper left, we're going to take that and we're going to turn it to the left side. So upper right to the right, upper left to the left. Now when this fits inside the mouth, this is a lower arch, so it's going to look a little bit different than me holding it in, but this is what it's going to look like inside the mouth, where the retainer itself is on the buccal surface. The band is always facing towards the tooth you're working on. If it's a lower, in this case, the U is facing down to make the letter N essentially, and the smaller end of the band is going towards the gum line. But if I were to take something that is set up currently for the upper left, and you know that because the band's to the left, and if it's for an upper, the U shapes up, but if it's a lower, it faces down. If I try to put this in the lower left quadrant, look what happens. That is now not on the buccal surface, and if they try to bite together, they're gonna bite on the retainer. So even though this works for the upper left because the band's to the left, it will work for the lower right. So upper left to the left, upper right to the right, in opposite quadrants work together when we're talking about the uppers versus the lowers. Now, what a lot of dentists and EFTAs will use in addition to the retainer system is a wedge. So this wooden wedge comes in different sizes and variations and colors, but it typically is wedged in through the lingual embrasure. So that's that little triangular space between your teeth and gums in between teeth. It gets wedged in there and it helps to create a really tight contact. It ensures that the band alone doesn't pop out, and it creates the correct contour with that. So it gets pressed in there through the lingual embrasure. So you know exactly what to set up for based off of looking at the patient's chart. Then what happens is after the tooth is numbed and prepped, you hand the doctor the retainer, they go to place it in, and you'll notice there's some frustration with these retainers because they actually have to get this band around the tooth. So if I know I'm working on a molar, I'm gonna go and keep my band really large. But if I know I'm working on a premolar, what I can do is actually take that large knob and turn it to make the diameter just a little bit smaller. You don't want it the exact size because we still need to be able to fit it around the tooth. And once it's on the tooth, they'll cinch it even tighter, almost like cinching a belt closed. So they'll keep turning the knob until that gets tighter and tighter around the tooth. But it saves them some time and they don't have to adjust as much. So in review, this is your Toffelmeier matrix retainer. It is a posterior matrix system designed to create a temporary wall between the tooth that it surrounds and the tooth adjacent to it. So as you place that mesial or that distal restoration, it doesn't stick to the tooth next to it.
When you're putting it in, you're always going to want to make sure that the prongs are facing skyward so that you can see everything. So you should be able to see the vise and the horizontal slit. Your band should look like a V, not like a tent. So what happens a lot of times is we close it together, and then when we go to put it in the retainer, we do one of these numbers, a little acrobatic act, and we don't want to do that. So we're going to take that and we're going to slide it straight down into those little horizontal slits without creasing this. That's important. If you crease it, this is not going to create the natural contour of a tooth, so make sure that you're not creasing it. If you want this to work for the upper right, then what you'll do is you'll take that band and you'll direct it to the right. If we want it to work for the upper left, the band is directed to the left. Noticing that the smaller end of that band, that smaller end of the loop, is facing the same direction as the prongs, which would be near the gums. When we're done and have it positioned where we want, we're going to tighten it into place with this screw. If we want to change the diameter, we'd use the larger knob. And opposite quadrants are the same. So if this works for the upper left, this also works for the lower right.
Alrighty, I have a confession to make. When I learned how to set up a syringe, I was super nervous. Like my hands were shaking and sweating because I hate needles. Like if they're coming towards me, I am really nervous and I don't want anything to do with it. Even though I've taken a phlebotomy course, I've sat and watched injection after injection, whether it be Botox in a dental office or infiltration and mandibular blocks, all of these things for medical procedures. But darn, if that needle's coming towards me, no, I want to run out of there. So rest assured, when we learn how to set up syringes in class, we're learning how to do so safely to protect ourselves from any kind of needle stick injuries. We're going to protect our patients by properly assembling this and making sure that we're not using expired materials or needles on multiple patients. We're going to learn the safety protocols, but we are never going to give each other injections. We are not legally allowed to, as a dental assistant, allowed to give a local anesthetic injection. We are allowed to place topical anesthetic, which is a gel that is placed on the injection site so that when the injection is given by either the hygienist or the dentist, which are qualified personnel, is more comfortable, doesn't hurt. So there we are. Let's see how it's set up. Going through the parts of the aspirating anesthetic syringe. What we're going to look at first is going to be the threaded tip. This is where you're going to screw on your needle. Your piston, which goes up and down inside of the syringe with the harpoon on one end and the thumb ring on the other, where the dentist would hold, or even the hygienist would hold, to actually plunge and put the medication into the patient's mouth. You've got blue and yellow needles. Typically, your blue is going to be for your maxillary and your yellow going to be for your mandibular. With the clear end being your hub end that's screwed onto the syringe, and the blue the injection side. Looking at your anesthetic carpules, you'll look for whether or not it has epinephrine in it, the expiration date, looking for any kind of discoloration, bubbles, looking as though some of the material has been used, because we do not want to use a carpule that's been used on another patient. You could also tell if it's been used by looking at the top in that diaphragm to see whether or not you see a puncture from the needle. We definitely don't want to use that on one patient to the next. You also want to utilize, if your office has it handy, some kind of safe needle recapping. Let's start by taking off the hub end of the needle. That's the clear side of the needle. Carefully taking the sterile needle, you're going to screw it onto that threaded tip, making sure that it's screwed completely down where the plastic meets the metal without over tightening it to where it's really difficult to take off later. Then you will place your hands on the piston, pulling it back. Otherwise, you're not going to be able to fit your carpule in there, and you'll know because you won't be able to get it in. But you're going to pull it back so it's out of the way, placing the rubber end towards the harpoon, the little part that looks like a fishing hook, and the metal cap towards the needle. And you'll notice that it's kind of loose. So you're going to firmly hold that and spank the thumb hole so that it engages with the harpoon. Always make sure that you're handling needles safely. These I really like, the protectors, because if you were to go to recap it, acts like a shield so you can't accidentally stick yourself. One way that you can check whether you've assembled it properly is to give it a little bit of a squeeze to make sure that that fluid is coming out. But let's say that your office doesn't have one of these needle protectors. You can simply scoop and press that lid on as a safe way for you to recap that needle without injuring yourself. Now, to disassemble it, you essentially work backwards. You're going to quickly pull back on that piston, slide down and remove the anesthetic, which sometimes that rubber stopper gets stuck on the harpoon, which is fine. Just make sure you're not using your finger to pull it off the harpoon because that's really sharp and can cut you. That can be disposed of. And the needle is going to be unscrewed. Now, I like to bend the needle when I take it off and put it directly into our sharps container. Do not try to recap it with the hub end because you can accidentally stick yourself in that side. It's still considered contaminated. So you'll put that directly into your sharps container, which should be located in each of your operatories. You can put your carpule in there also.
Every general dentist and specialty is going to utilize some form of charting, whether it be paper charting, but more popularly, the computerized systems. We need some way to document what treatment needs to be done, a patient's ledger, their progress notes, the schedule. So this is going to introduce a little bit more of the clinical charting for a patient.
This new clinical skill that we're introducing is clinical charting. This is very useful because even though in your office you might not be using paper charts, you're still going to be using computerized charts, which later on we'll see how to put a patient into a database, how to schedule them, how to treatment plan things on a computer. But we're going to start off with paper on everything. It just seems to make things much more simple once you do move into the computer because you understand what is being visualized there because we started with these basics. Now, what we're looking at, it is important for you to remember that everything on the right side of your paper is going to be the left side of the patient's mouth. And everything on the left side of the paper or screen is going to be the patient's right, which is why we see tooth number 1 located in this corner here. This is a lot like if you remember in school taking those tests where I'm going to draw a little thing here where you would have this diagram that would say, all right, if I were to take this two-dimensional thing and fold it together, what 3D object does it make? Which this one happens to be a cube. So if I'm looking at this particular tooth diagram or chart, if I were to take this picture and this picture and this picture and fold them together, what do I end up with? Well, I end up with a 3-dimensional tooth is what I end up with. You still have your maxillary, you still have your mandibular, and you have your patient right and your patient left. And we still have our midline that runs right down the center of the mouth, splitting us into those rights and lefts. But what it's trying to show us is that there's a buccal, an occlusal, and a lingual surface. So here's a little cheat sheet for down the side so you know exactly what you're looking at. Buccal, occlusal, lingual, occlusal, buccal. But let's add some more to that to kind of make sense to it. So we're going to actually use the same color coding that you see on your color-coded sheet. Everything that is considered a buccal surface, I'm going to highlight in green. Now on the mandibular teeth, it's going to be the lower picture drawn because this is on the outside of the picture, the outside of the mouth. On anterior teeth, they are not actually called buccals. They are going to be your facial. So everything that's purple is a facial. Everything that is blue is a lingual. Linguals are surfaces that are on the inside of the mouth, closest to the tongue. If it helps, imagine that empty space right there in the center of the picture is where your tongue is at. So comparing the blue surfaces and the green surface to each other, blue is closer to the inner portion of this picture. Last but not least, represented in red is our occlusal surfaces. And we'll get into what are the little extra projections on the side there, what surface is that representing. Remember, red is occlusal, green is buccal, blue is lingual, purple is facial. And that's why we have our BOL, LOB down the side there. Let's give us a clean slate of what we're looking at. Let's go through and do some basic charting. We'll start off with the extraction. So there are quite a few different descriptions as far as extractions go, and it just depends on what is going on with the procedure. But you have simple extractions, which are erupted teeth that are in the mouth, and we can start working at and getting them loose and extracting them. And then you have surgical extractions. Surgical extractions are a little bit more involved where you have to remove some tissue to access the tooth. So, for example, an impacted tooth. To chart the difference between the two, number one will be a surgical extraction. Surgical extraction, circle. Number two will be a simple extraction with a simple line. Notice that we're either circling the entire tooth or putting a line through the entire tooth. This is really important as we start learning more procedures as we go, that you can identify the difference between extractions and other procedures. So surgical, circle, simple, simple line. We also went over sealants today. So sealants, which are a preventative measure, are typically placed on the first and the second molars. First molars erupt around age 6, second molars around age 12. So we try to put them as soon as possible on. So on number 3, we're going to chart that it needs a sealant. All it is an S on the occlusal surface. Now, depending on if it's in red or blue, red is going to indicate that it's treatment that needs to be completed. Just like a stop sign or a stoplight demands your attention when it's red, when you see red in a patient's chart, it's demanding your attention. Blue means that it's completed, it's done. So if you were to see a blue S, that would indicate a finished sealant. All right, let's keep moving. We're going to work on the other side, the maxillary left. On number 16, we're going to chart an occlusal filling, which is just simply a dot right in the center of that occlusal surface, which we know it's the occlusal surface because we're using our little cheat sheet off the side, the BOL, LOB. Everything that's in that row must be an occlusal surface. And if we're just thinking about the shape of the tooth, it makes sense that we're marking that as the occlusal. 15, we're going to mark a buccal restoration. All it is a dot right on the buccal surface. That surface, in comparison to the one that we're putting an X on, is closer to the outside of the picture, whereas the one with the X is on the inside. Number 14, we're going to do a lingual restoration. Lingual, towards the tongue, towards the inside of the mouth, towards the inside of the picture here. Now let's do a combined restoration here, where it is an OB. What you'll be charting is the occlusal surface and the buccal surface. So when you have more than one surface being restored, just break it down and make it easy on yourself. This two-surface restoration and occlusal buccal, we can just combine what we marked on 16 with what we marked on 15. So on number 12, we're going to do an occlusal
lingual, O-L is what we're looking at here. Let's jump down to the mandibular arch and do the same thing. On 17, we're going to do an occlusal. On 15, we're going to do a buccal, but notice that our buccals on the mandibular arch are actually the bottom illustration because it's on the outside of the picture. Whereas a lingual on number 19 would be closest to the tongue. An occlusal buccal on 20 would look like this, so an OB, two surfaces, and an occlusal lingual on 21 would look like this. I did tell you that we were going to talk about what we were seeing on the occlusal surface, those extra little projections that we're seeing, the little wings. I'm going to color on the mandibular right a couple of these wings green and a couple of them purple. Every surface that I'm coloring green is closer to the midline than the ones that we're coloring in purple. Which means that the green surfaces represented are like a to-go box. We're folding out the interproximals. The green are the mesial surface because they're closer to the midline. The purple is going to be the distal surface because it's distant or it's farther from the midline is what we're seeing on those. So if I were to erase those, and I were to say on tooth number 28, chart a mesial occlusal, an M-O. We already know how to chart an occlusal. We've done it several times. But now we need to know which of the elephant ears, which of the interproximals we're charting. We need to pick for mesial the one that is closer to the midline. For a distal occlusal, the distal surface on 29 is further from the midline, with us having that occlusal surface. And now it seems like we're representing it as being two different, restorations or two different fillings. Really, they're going to be connected, especially with the interproximals. They have to be so they can get down in between the teeth. They're actually drilling and accessing that cavity from the occlusal surface. If I had an M-O-D, M-O-D on 30, this is what it would look like. And you'll notice that the distal 29 and the mesial 30 both need restored. And that's very common because these interproximal caries, which are also known as kissing caries, this is a communicable disease. Mutant streptococci, which causes the disease to occur, it's highly communicable. It's pathogenic, meaning it causes the disease. It can spread from tooth to tooth. And because they are contact points and they're touching, it's going to spread a little bit easier. If I were to have an O, B, buccal, L, lingual, that's what it would appear like. All right, let's work on these anteriors. So the anteriors obviously have some different terms associated with them. These are going to be from your cuspid to your cuspid. These have facial surfaces and they have incisal edge surfaces. But you might be a little bit confused because you're not seeing an incisal edge actually represented there, and that's okay because we don't typically do just an incisal edge restoration. It would be too small and too difficult to get it to attach to the tooth without it coming off easily. We would actually restore the incisal edge along with either attaching some to the facial or front of the tooth, to the lingual or back of the tooth, or sometimes both. That more surface area we have, the more likely it's going to bond or stick to the tooth better. Let's look at just a facial surface on number 8 versus just a lingual surface on number 9. So off to the side we saw that we had our B, but keep in mind that it really is an F when it comes to those anterior teeth. So even though your BLOB, your B-U-L-L-O-B is your trick, know that buccal is interchangeable for facial on the anterior teeth. Once we know what the difference between our facial and our lingual surfaces are for the anteriors, all that we need to do when we start adding different letters to that is to shift that dot to one area or the other. For example,
Number 7, if I'm going to do a mesial facial, an MF, it's going to take that facial dot and shift it towards the midline. But if I'm doing a distal facial, like on number 6, it's going to take that dot and shift it away from the midline. On the cuspid, you'll see that it has that extra little projection. It's just because a cuspid has more of a rounded shape than what your oblong incisors would have, and they're trying to represent that obviously on a two-dimensional piece of paper. On number 10, we're going to do a mesial lingual. We find the lingual surface closer to the inside of the mouth and mark closer to that midline. Whereas a distal lingual on 11 would be on the distal side of that lingual surface. Now we need to add in 2 more, one of them being an incisal edge filling. An IF on number 23. It would be on the facial surface, which we would know which is facial by looking on the side and just understanding what we're looking at. But instead of it being in the center or towards the midline or away from the midline, it's going to involve the incisal edge. An IL on 24 would be the same except on the lingual surface. Now be careful not to mark it. I'm going to mark it incorrectly in, let's do blue. This is a different type of restoration, what's right at the gum line. That is not an incisal edge filling, so do not mark it at the gum line. That's something else that we're going to learn here in just a minute. If I have an IFL, like on 26, I would mark the incisal facial and the incisal lingual, so we know that it's wrapping around, almost like a hat basically, right on the incisal edge. We can have incisal edge restorations even on cuspids because they are to an anterior tooth. They have that cuspal or that incisal edge. Even though it comes to a cusp or a point, we may still have to restore it in that manner. Now I have left just what's called a class 5 restoration. Later in your chapters, you'll learn about G.V. Black, who classified our restorations or our fillings based on where in the mouth and what surfaces and how many surfaces are involved. But the one that we use now still is the class 5. Class 5, utilizing the Roman numeral 5, which looks like a V, is a gum line restoration. So let me show you on number 22 the difference between a class 5 facial and a class 5 facial and an incisal facial on 23. 22 is a class 5 facial. 23 is an incisal facial. All right, but you can have a class 5 on any surface. You could have a class 5 on the lingual, which I just marked on 22 also. You could have a class 5 on 32 on the buccal. You could have a class 5 on the buccal of a posterior tooth. All that it's saying is it's at the gum line is what it's telling us when it comes to a class 5 restoration. Instead of it being right in the center of the tooth like a buccal or a facial or a lingual is, it's right at the gum line itself. So these are kind of our basic skills for charting. We're going to continue building upon these. We'll add in root canals, crowns and bridges, and different things like that. We're also going to see how we chart this on a computer, which is going to look very similar, but it's going to involve a different manner of doing things and understanding what are called procedure codes, which we'll get into as we progress throughout the course. So what you should have in your binders is a blank version of this. You can slide this into the sheet protector, just like you've been putting your blank tooth diagram in, the one that had the 15 items where you labeled the anatomy. Go ahead and make sure that you slide this in there, a blank version. And then you can use your Expo marker to practice on this numerous times over and over and over again without having to print multiple copies of it. So there you have it. There's a new clinical skill.
The patients that we're going to see at the pedodontic office is going to be your adolescents from birth up to about age 18. You occasionally will have patients that are chronologically adults, so you might have a 19, 20, 21-year-old, but they may be a special needs patient that they're just more accustomed and a better fit to stay in the pediatric office. Pediatrics can be a lot of fun. but it can also be a little bit more stressful because you do have to take the extra care and patience with that patient because they just can't understand everything. They're going to cry a lot more easily than, say, your adult patients. They're going to be fidgety. You're also going to see a lot of times utilizing general anesthesia, whether it's in office or referred out to like a surgery center or a hospital dental clinic. Like Children's Hospital has an area where a lot of dentists will send out their pediatric patients if they need extensive dental care and they need a lot of work done. It's probably easier because they're not going to be fidgeting around to put them under general anesthesia. Some pediatric offices do this in-house. They bring in an anesthesiologist, they put the child to sleep, they do the dental work so that everything's super smooth and simple. The kid's not, overly traumatized by the procedure because they're asleep and they're on their merry way. You will, however, see some special things that we do more often in the pediatric office, like SDF application, space maintainers, than what you would see in, say, a general office. Also, if you like fun scrubs with different characters on them, this is kind of going to be your jam because a lot of times they are wearing those things to make it a more welcoming, fun environment. Building that repertoire with our pediatric patient, making sure that they feel comfortable because ideally we want to see them in the office before age 3. You don't have to take your child to a pediatric dentist. I've never taken any of my children to a pediatric office. They've always gone to the same office that I'm a patient at. Now I can take a look into the pediatric office and a few of the different things that you might expect to see on the day-to-day.
Tell, show, do is the most accepted behavior management technique by parents for their young children during an appointment. First, tell the patient what the tools are by using fun names. For example, the suction is Mr. Slurpee, the air water syringe is the squirt gun, and the scaler is the toothpick. Second, show them what the tool does before going intraorally. Let them see their eye in the tooth mirror and use the special toothbrush, aka the polisher, on their finger. Third is do. As you use each tool that you previously described, remind them of the fun name as you introduce it into the mouth. One other helpful technique is to start on the anterior teeth first and then move posteriorly to get the patient accustomed to you working in their mouth. Number 1, get sunglasses for your child's safety glasses as they're usually more sensitive to the light. Number 2, fold the patient cover in half so that it won't get in the way as easily. Number 3, label the cover with the patient's name for an extra touch of customer service. Number 4, use the labeled cover to place the instruments on during multiple family exams to remember whose instruments are whose if your dentist likes to do all the children's exams at the same time. Number 5, if your patient is scared to lay back in the chair, sit in each knee to provide some or all of your treatment until they feel more comfortable.
My name is Dr. Ana Vasquez. I am a pediatric dentist in Fishers, Indiana. Today we're going to be treating an 8-year-old with a medical history consisting of attention deficit disorder with hyperactivity. Patient has some work that needs to be done in all quadrants, which includes stainless steel crowns. For some of you that do treat children all the time, you know that children can be extremely unpredictable. This patient is going to be treated with a conscious sedation. With a conscious sedation, it's extremely important that we protect our airway. That's one of the main reasons that I use the Isolite. Not only because I am protecting that airway, but also it makes me be more efficient since I can be working on 2 quadrants at the same time. We're going to be working on the right side. We're going to be doing 1 stainless steel crown. I will use the Isolite just because, once again, I don't want anything to go into the airway that this patient can either swallow it or even worse, aspirate.
Anesthesia is a safe way to keep your child comfortable during care in the operating room. General anesthesia is a series of medications given to your child before and during their procedure, providing a deep sleep. Your child will not remember the procedure or feel discomfort. An anesthesiologist is specially trained to oversee the procedure for your child. Before the procedure, the anesthesiologist will meet with you to talk about the medications and evaluate your child. Your child's dentist will recommend general anesthesia when it is necessary, as it allows your child's dentist to care for them in a calm and safe way. Reasons for general anesthesia include treatment of painful and serious disease, children who are very young, fearful, nervous, or have special needs which keep them from cooperating for care in the clinic that may take several visits.
Reliable method for carrying out a pulpotomy on a deciduous molar. The subsequent restoration with a preformed stainless steel crown is also covered. On the screen, you can see a selection of materials and instruments that you may find useful in undertaking this procedure. It must be noted that clinically, when undertaking this procedure, local anesthetic is required. Rubber dam should be used when undertaking a pulpotomy. This will protect the airway, increase patient comfort, and reduce the chance of bacterial ingress. Thread floss through the holes on the clamp. This accommodates retrievability in the event of aspiration. Gently try the clamp on the tooth. If you are happy with this, it is now time to fit the rubber dam. Punch the appropriate holes in the rubber dam. For this exercise, this will be the tooth undergoing the pulpotomy, and those immediately adjacent to it. There are many techniques for rubber dam placement. For ease, a split dam technique can be used. For this, the interproximal dam between adjacent holes is cut. This is particularly useful if the tooth is to be restored with a preformed metal crown. This will be demonstrated in your practical. Ensure the dam is fully seated by flossing through the contacts. The dam can further be secured using rubber wedging material. Gain access to the caries using the diamond fissure burr within the high-speed handpiece. Ensure that you establish clean margins circumscribing the cavity. Deepen the cavity and remove the caries overlying the pulp chamber. Widen the cavity sufficiently to ensure access to the pulp horns. These are usually located in the corners of the tooth. Gain access to the pulp chamber using the high-speed handpiece with the diamond burr. Ensure that all the overhanging dentin is removed. At this point, you should observe bleeding from the pulp. If bleeding does not occur, and the pulp appears necrotic, then it can be assumed that the pulp is non-vital, and a pulpotomy would not be the appropriate course of treatment. Remove the coronal pulp with a large rosehead burr in a slow handpiece. Alternatively, a large excavator can be used. The pulp stumps should be visible. Care must be taken when removing the pulp tissue overlying the cavity floor, as this is very thin and overzealous preparation can lead to iatrogenic perforation. When you are happy that the inflamed pulp has been removed, it is time to achieve hemostasis. For this, place a cotton pellet soaked in ferric sulfate onto the remaining pulpal tissue and canal entrances. Use tweezers to deliver the cotton pellet into the access cavity, pressing firmly. Leave the ferric sulfate in contact with the pulpal tissue for 1 to 2 minutes. Gently remove the cotton pellets and observe hemostasis. Fill the pulp chamber with a zinc oxide eugenol material. Use a flat plastic and a plugger for packing this.
Maybe you've heard this spoken in the dental office already, but what is SDF? It's an antimicrobial liquid that can help stop tooth decay and help with sensitivity. It's really beneficial, particularly for children. The treatment is fast, the teeth do not need to get numb, and it can help buy time for the very young, fearful, or special needs patients that may otherwise need sedation or general anesthesia for traditional dental treatment. It's really inexpensive, non-invasive, and it is 80% effective. How it does that is through its ability to inhibit mineral demineralization. It also promotes mineral remineralization and helps to protect the tooth from degradation. To simplify that, it boosts your tooth strength. It makes it stronger by remineralizing that enamel, that top outermost layer of the tooth. It'll help kill the bacteria that breaks down the tooth surface and from spreading to the teeth adjacent or next to it. Not every patient that has dental caries is going to be a candidate for utilizing SDF because there are some significant disadvantages, primarily going to be your aesthetics, that it will stain the decay, it will discolor fillings, and it will stain surfaces. So you do have to just be careful not to get it onto the operatory chairs, countertops, patients' clothing. If you're not using it properly, you could spill it. You also want to take caution to keep it off the gums, as it can stain it too. You can put some Vaseline on the gums if you're going to be working close to that. The metallic taste isn't something that lasts. It's going to be something that goes away rather quickly, but it is something to be thinking about, especially if you're working with a young child, special needs patient that might be a little bit sensitive to that sensory input. This would be good for, say, a patient who, again, wouldn't fare well for regular dental treatment. We don't really want to sedate the patient. Maybe it's a baby tooth that is going to be falling out kind of soon, but we want to keep that decay from spreading. We can apply the SDF. I have seen some providers, when they remove fillings from the pediatric mouth, they'll put SDF in before. Now, this is not something for like us adults, especially on an anterior tooth, that, oh, we have a filling, we're just going to stop it like this. No, that would be a better option to go ahead and remove that cavity and replace it with a restorative material with composite or tooth-colored material being on the front. And if we're thinking cost effectiveness, or maybe the patient has bruxism, which is clenching and grinding of the teeth, we might opt for the silver amalgam fillings, which are a lot stronger. They place the filling as an additional measure of preventing any kind of decay that could have been left behind from reoccurring. Applying SDF is actually rather easy. The tooth needs to be dried prior to application. You can dip a micro brush into the SDF and press that against the side, making sure you don't have excess that's going to be dripping all over the place. You're going to put it onto that lesion, onto that decay, for about 2 to 3 minutes. If we're working with the interproximals, we're going to want to use what we call super floss, which is like this thick, spongy floss that can soak up that SDF, and we can put it down and just leave it there interproximally. You can see in these pictures where we're treating these small lesions that, you know, we don't necessarily want or need to do a full-on filling. We can place it down in there to protect that tooth. Afterwards, apply your fluoride varnish, and the patient should be advised not to drink for about 60 minutes. Reapplication may be necessary anywhere from 3 to 12 months after the initial application. When I was in middle school, I thought it was the coolest thing that people had braces. I thought it was cool that they got to change different colors depending on the season, their favorite colors, sports teams, all those things. And so I really wanted braces. And you know what? My wish came true. They weren't as fun as I thought that they would be, but they also weren't that bad either. I went through traditional braces at an orthodontic office where they specialized in malocclusions, which is the correction of improper bites. This could be because of thumb sucking, using a pacifier for an extended period of time, causing what we call an open bite. It could be overcrowding, overjets, where the teeth jet out and they don't line up the way they should. Things not erupting or coming into their functioning position. There are a lot of reasons why a patient ends up in an orthodontic office. They could be going through early childhood orthodontics where they're getting a first set of braces at a young age, getting them off for a few years, and then getting a second set. Thankfully, I avoided that. I just had to have the one set, and I think it was like 18 months, so I got really lucky that it wasn't too hard of a case. And afterwards, I had a nice, straight smile. There are a lot of people that think that orthodontics is purely aesthetic. There is a huge aesthetic factor, but there's also a lot of functionality to it. If your teeth aren't lining up properly, they might be rubbing up against each other, and that abrasion can wear away the enamel. You could have trouble properly cleaning your teeth because of the crowding. Maybe the way that your jaw is lined up, there's pain with popping and clicking. It could also be that it's causing an improper speech, like a speech impediment, because of the way things aren't lining up the way that they should. These all would be functionality reasons why orthodontics may be recommended for our patients. You see sometimes kids getting braces, but also adults. There's no age limit on you can't have braces past the age 30. You can go get braces. Doesn't mean your insurance is going to pay anything for it. A lot of insurances, if they have orthodontic coverage, won't have adult coverage. A lot of times that particular benefit stops at age, say, 19, and it doesn't cover 100% of the braces either. I see a lot of times it's up to age 19. They pay $1,000 maximum or $2,000 maximum. That's all they're going to pay towards it at 50%. So let's say your braces cost you, we'll just do simple math here, $4,000. Well, they'll pay 50% of that procedure up to your maximum, which in this case is $2,000. That's going to be how that insurance kind of simply works there. But nothing says you can't pay out of pocket. You can go get care credit. You can pay cash. You can pay with a check. There's other options to getting braces. And it depends on the patient too. Like some patients, they have to have traditional braces where you're going to see the brackets cemented to the teeth with the wires. Other times they are candidates for clear aligners such as ClearCorrect or Invisalign. We can start with talking about traditional braces and the instruments, the numbering system, the different skill sets that you would need as an orthodontic assistant, and then we'll talk about our clear aligners too.
Instruments that we commonly use in the orthodontic clinic. We'll just go through them one by one, and I'll kind of explain what each of them are and what their name is. So first we have the intraoral mirror, or mouth mirror. Some people call it a mouth mirror. This is just used for, you can use it to retract people's cheeks like this, or you can use it to shine light on the back side of the teeth if you're working with a handpiece, or you can use it to look at the back side of the teeth or the retainer. So it's just kind of the mirror that you can use generally inside the mouth. This is called an explorer. This end is called an explorer, so it's like a spike. You use this to take off the colors or the O-ties from a patient's braces. It's like a cylinder that's sharp. Whereas this one right here is called, a scaler. So it's also sharp, but instead of being a cylinder, it's like a triangle. So it has these sharp edges. Normally this is used by hygienists and dentists to clean tartar off of people's teeth, but some assistants like to use it to remove the O-ties from brackets. The other end of these, so here's your explorer end. This end, you can see it's got sort of a little forked tongue, like a little snake's tongue. This is called a ligature director. So you use this to push an arch wire into place, or when you've cut a ligature wire, you want to tuck it under the arch wire, you can use it to do that. So it's called a ligature director. The other side of the scaler, so here's the scaler end, the other side of this is called a pusher. So this is meant for pushing bands onto the teeth or contouring bands into the side of the teeth so that it matches the contour of the tooth, and that's called a pusher. This is called an open Mathau. So it's a Mathau plier. It has this ratcheting end that ratchets shut. So when you click it, it locks closed. So you can grab single ties or chain and it will lock on there. So now you can just use it and it grabs a hold of them and doesn't let go. And then to release it, you just continue to squeeze, and this goes all the way down until it goes past, and then it opens. This is called an open Mathau because you can see right here at the end, the jaws only touch at the end, and here in the middle is open. So it's meant for really pinching things like that, as opposed to this one, which is called a closed Mathau. So the closed Mathau, it touches all the way from front to back. I prefer to use these when I'm working with chain, because these will tend to pinch it, and when you go to pull, it can sometimes cut it or tear it, whereas this one is less likely to do that because it's not such a pressurized, like pinch in one little spot. It kind of spreads the load over more area. So this is a closed Mathau, and it works just the same as the open Mathau as far as the ratcheting action. This is called a distal end cutter. So you can see it's got these jaws right here. This is a flat side and this is a cutting side, like a chisel. And so those meet together and they cut arch wire, they cut wire. And then this little round thing right here, it fits up against there, and that will hold on to the cut end of the wire so it doesn't fly off when you cut it. I'll demonstrate. So here's an arch wire. I'm gonna get a hold of the end here just to demonstrate. And when I squeeze, it cuts it, and you'll see that little round thing holds on to that little bit of wire. So when you cut the wire in the mouth, you just keep a hold of it nice and tight, and then you come here and you can let go, but that little bit of wire will fall off without it shooting into the patient's mouth. So it's called a distal end cutter. It's for cutting the distal end of the wire. This is called a ligature cutter. So it's like a wire cutter, but just much more expensive. It just meets with a flush cutting blades right here. This is for cutting like ligature tie and skinny wires like that. You can cut zinc string with it, you can cut chain with it. You don't want to cut arch wires with this because the blades are more delicate and it will, over time, will wear these down. For cutting arch wires, you'll use a distal end cutter, but this is for cutting anything else that's lighter weight than an arch wire. This is called a Weingart plier. So these are like this is your basic utility plier. So this is for use of putting arch wires in the mouth or taking arch wires out of the mouth. And they come in several different shapes and orientations, but they're all called Weingart plier if they are meant just as a multi-purpose kind of grabbing plier. And you can see they just touch here and it's open here. Now, for holding these, you can hold them however you want, and this goes for all of the instruments, but you want to be able to open and close it with one hand. So this is how I hold it. This works well for me. Some people do this, some people do that. It just, however you do it, you just want to be able to open and close it with one hand like this, because usually you're holding something with this hand and you're working with the plier with this hand. An open cotton plier. It's different than this one, which is called a loaded cotton plier or a latching or locking cotton plier, because this one has this little latch right here. So to open this, you just kind of push this up and that will release, and then it's like that, but then when you push it closed, that will latch shut. So we use these to hold these little cotton ends, and we use that to soak up liquid etchant and apply onto the tooth. And then when that's used, you just unlatch this, throw that away, clean it, and then you grab a new clean one after it's gone through sterilization. So open cotton plier, loaded or latching cotton plier. Most of our staff call this a loaded cotton plier, this one here. This is called a bracket holder. This is used for holding the brackets. When you squeeze it, it opens. When you let go, it closes. And it's for holding brackets, for placing on the teeth when we're putting brackets on. It's called a bracket positioner or a bracket holder. This is called a bite stick. So if we're gonna seat bands onto the teeth, you use this you put the band on the tooth, and then you can position this on the edge of the band and then have the patient bite down, and that will slide the band onto the tooth. And it has this triangular head, and you can use that head in different orientations to fit the different parts of the tooth. This is called a bite stick, and they come in different colors, but they all work the same. This is called a spatula. This is meant for a mixing spatula. This is meant for mixing up different two-part compounds. So like our band cement is a two-part with a liquid and a powder. So you have the liquid and the powder, and then you use this to mix them together, and then you scoop it up and use this to place that cement inside the band. So this is a mixing spatula. And some of them have a small head like this, and some of them have a longer, wider head, but they're both called mixing spatulas. This is called a bracket removing plier. Its jaws look like that. They don't quite touch, and you use this to remove brackets. So you get this around the bracket and you squeeze, and that distorts the bracket, gets it to pop off the tooth. You use these when you want to take the brackets off and not reuse them, because it distorts the bracket and you can't reuse them. Like if you're going to reposition the bracket, you'd use something else. But this is just for removing them and throwing them away. This is called a bracket removing plier. This is also a bracket removing plier, but that's specific for removing symmetry brackets. So those are the Symmetry brand porcelain brackets. This grabs onto the tie wings of the bracket, and then when you squeeze, this little arm right here puts outward pressure on the bracket, and it pops the bracket off the tooth in this direction. So this is a Symmetry bracket removing plier. This is a Clarity bracket removing plier. So this is for removing Clarity brand clear brackets. You use it similarly, but you get a hold of the bracket like this and squeeze, and it breaks them and is supposed to pop them loose. So that's for Clarity bracket removal. This is called a hammerhead plier. So this is a kind of a specialty plier for putting bends in small NiTi wires, or nickel titanium wires. The way this works, you can see there's kind of a C-shaped end here, and then this fits into that C, and it will bend a nickel titanium wire past 90 degrees, and it leaves a bend in place. So this is for if you want to put a bend in the wire distal to a 6, you would reach back there with this, you'd get that on there, and then it puts a bend in the wire, just like that. And you want to use this so that it bends the wire toward the tooth, so that it's not going to poke anything or get poke the gums or irritate. So it has two sides, so it looks kind of like a hammerhead shark, is why it's called a hammerhead plier. And it bends the wire in the same shape as that C. So if you want to bend the wire facing that way, you'd use this end. If you want to bend the wire facing that way, you would use this end, because the bend would end up looking like that C. Just like that. Hammerhead plier. This is called a bird beak plier. This is a really long bird beak. They have shorter bird beaks, but the way you know it's a bird beak is one side is sort of a square pyramid and the other side is a cone. So that's what a bird beak plier looks like. This is for putting bends in a metal arch wire. So the bird beak has a cone and a square pyramid. This is called a 3-prong plier because it has 3 prongs, one on one side and 2 on the other. This is also for putting bends in wire. When you squeeze a wire like this, it will put a little bend in it, and I'll demonstrate here. So I grab this and I can put a little bend in it just like that, because the one grabs it on one side and the 2 grab it on the other, and it just puts a V-bend in a wire. So this is a 3-prong. We'll use these when we are shaping a retainer wire. When we're going to place a fixed retainer, you'll use a 3-prong. This is an arch forming plier. So you notice it's an arch forming plier because once it looks like a smiley face. This plier is always happy to see you. So one side is like a convex shape and one is a concave shape, and they fit together like that. And what this is for shaping arch wires or shaping lingual arch wires. When we place a lingual arch, we'll use this to contour the wire. So you can see, if I were gonna use this on here, it would place kind of a gentle, kind of rounded bend in the wire. And that's what you can use it, if you use it gently, to kind of put a gentle curve in the wire like that, arch forming plier. And lastly, these are called torquing pliers or a torquing pair. These work together to put torque for just one bracket. So the way these work is you get a hold of the arch wire with one like this, and then you slide this other plier in between there like that, and now you've got a hold of it, and then you can put a bend in the wire like this, and that way it doesn't bend the wire here, it doesn't bend the wire here, it just puts a torquing bend here. Torquing is where you kind of upright the tooth or flare the tooth like this. So when you're done, this might be hard to see on the video, but right there where we put that bend in, there's going to be a little torque right there.
The Palmer notation system. The Palmer notation system is the numbering system utilized in the orthodontic specialty. The ortho office does not require any specialized training, so when you leave our program, you will be able to jump right in and start working. The numbering system that they use is very particular to their specialty. If you're working in other avenues and specialties of dentistry, you more than likely won't ever work with this numbering system, but it is still very helpful information to know. The orthodontic numbering system, you can think of it a lot like if you are trying to straighten the teeth, you are going to want this in the most aesthetic way possible. So you would want the maxillary and mandibular to be mirror images, but also the right and the left to be mirror images. So instead of numbering the teeth 1 through 32 or A through T for the pediatrics, we utilize them from the midline out. That way, from the midline out, everything is symmetrical like a mirror image. all of your central incisors of the adult dentition are 1s. All of your lateral incisors are 2s. Your canines are 3s. Your first premolars are 4. Your second premolars are 5s. Your first molars are 6. Second molars 7, and third molars 8. So you're going from the midline out. But then that can be a little confusing because then we have 4 of each number in the mouth. And that's where the splitting of the quadrants, or the 4 areas of the mouth, come into play. Think of it as the upper right quadrant as quadrant 1, upper left 2, lower left is quadrant 3, and lower right is quadrant 4. Now we could number it as 1, 1, meaning the first quadrant and the first tooth in it, or 1, 2, with a semicolon between them, meaning the first quadrant and second tooth, which in all of our other avenues of dentistry, we would typically call that tooth tooth number 7. So if it helps, go over top of these teeth, starting with what would be the patient's upper right. So in this case, if we're looking at the screen, it's on the left side of the screen. You'll see where it's written right. Backwards thinking, because it's as though the patient is laying in front of you, mouth stretched wide open. It's the patient's right. So it's opposite on paper and on screen. We would start with number 1, work our way over to the other side with 16, drop down to 17, all the way to 32. And that's going to help us to translate between one system and the next. We can do the same thing with the pediatric mouth, but this time we're using letters rather than numbers. So all the centrals are A's, laterals B, cuspid C, first molars are D's, and second molars are E's, working from the midline out. The little brackets that you see by the numbers and the letters are what are helping you to identify which quadrant. And so as you can tell in the little illustration in the center, it's as though we draw a mark down for the midline and through the middle of the picture like it's the upper and lower. So you can kind of tell if the bracket looks like a backwards L and there's a 2 on it, that would be what we normally call tooth number 7. If it looks like a normal L with a 5, that's what we would typically call tooth number 13. So it's kind of a translation from one system to the next. And you can actually find this in your textbook on the back inside cover. So the hard part on the back of the book, there's all the different numbering systems. You'll see illustrations of the teeth. It's a fantastic resource of the Palmer notation system. In this training video, we're going to go through the placement of elastic separators and the elastic ligature ties that are placed on each individual bracket to hold the arch wire into place. We're going to start off with the elastic ligatures and removing and replacing them. This is the fun part of having braces, where you get to pick the different colors of rubber bands that you want on each tooth. Sometimes patients will pick the same color for both the top and the bottom. They might alternate every other tooth with their school colors or their favorite colors. So it kind of just depends on what they pick. So what we'll do to remove them is we're going to go to the tooth that we want to take it off of, and we're going to carefully get like an explorer or a scaler up and underneath the ligature itself. We're going to pop it off. To replace them, you're going to use what are called Matthews pliers, that when you squeeze them together, they lock into place so that you don't have to keep squeezing them when you have the ligature in the nose. To unlock them, you're going to squeeze them until you can hear them completely click open and release. You're going to go over to your ligature tree and you're going to grab it carefully with the side of the needles. Don't cover the hole, because then that makes it so you can't actually get it around the bracket. Go off to the side, squeeze until it's clicked and you don't have to hold them anymore. Pop it off. Go back to the tooth that you were working on
loop it over one of those 4 corners. So each of these brackets have 4 corners. Loop it over one corner, and I always like to hold it with one finger so it stays in place. And loop around. And then squeeze until they're released. And you would do this while the arch wire is in place, but our models have it removed just to make it a little bit easier for you. Do be careful with the models that sometimes if you're a little too rough, you can pop the brackets off of these plastic teeth. So that's how you put on and remove the elastic ligatures. Let's look at how to place the elastic separators that you'd actually put in between the interproximals of posterior teeth prior to the brackets being placed, because what it does is it helps create a space for the molar bands to then go around the tooth. You're going to take your separating pliers that when you squeeze they open. You're going to place them inside the loop. When you squeeze they open. You're going to go over to the interproximals of a posterior tooth, squeeze, and you can press down just a little bit so that it flosses down in between the teeth. And that stays in there for a few days to help create that interproximal spacing for the molar band then to go around the tooth. So these a lot of times fall out on their own, and if they don't fall out on their own, then what you'll do is just go back through like an Explorer or Scaler and just carefully work those out.
Oral hygiene while in orthodontic braces is challenging, but really important for the overall success of the case. If a patient isn't properly brushing and flossing, the gums can become inflamed, preventing them from being able to be moved where they should be and causing other issues down the road. Knowing our patients' options when it comes to cleaning between their teeth, whether it be flossing or brushing, is important so that we can show them and teach them. So let's take a look at those.
Not enough. If you just brush, food and debris get left behind. The Waterpik Water Flosser is the easy and most effective way to clean between teeth. To get started, follow these simple steps. Fill reservoir with warm water and place firmly on the base. Select a tip that's right for you. Click firmly into handle. If this is your first use, you'll need to prime the pump. Number 1, set the pressure control to high. Number 2, point the tip into the sink. Number 3, turn on until water flows. Number 4, turn unit off. Now let's get on to water flossing. Start with lowest pressure setting. Lean over the sink and place the tip in your mouth. Turn unit and water on. Partially close lips to prevent splashing and let water flow from your mouth into the sink. Aim the tip at the gum line. For best results, start with your back teeth. Move along gum line, pausing briefly between teeth. Floss front and back side of teeth for 1 minute a day. The Waterpik Water Flosser removes up to 99.9% of plaque from treated areas and is up to 50% more effective than string floss. You can have healthier gums and brighter teeth with the Waterpik Water Flosser.
Clinically, we might find ourselves having to floss for our patients that are undergoing orthodontic treatment. We'll take a look at some ways to use the super floss for both the braces and the permanent retainer that they may receive after they're completed with their orthodontic treatment.
With a regular floss threader and floss. So the one thing I like to do is I like to tie my regular floss on my threader so it doesn't constantly come out of the loop as you're going through and flossing your patient. It'll help you save a lot of time in the long run. One other thing you can do, you can curl it. So just use your thumbnail like you're going to curl ribbon, and you just kind of curl it a little bit. That'll just help guide it in the molar region a little bit easier. When you floss the anteriors, instead of coming up and kind of poking your threader into the gingiva, come down away from the gingiva. And the biggest complaint I hear from hygienists is how long it takes, so they just don't even floss their ortho patients. But the more you do it, the faster you'll get a little bit of practice. So I'd recommend just toughing it out those couple patients, getting a good feel of how to floss ortho. Then it'll make your patients very happy how thorough you are. So same thing on the anteriors on the bottom, come up away from the gingiva. And if they have a kind of a little space, sometimes I'll just go straight through the teeth. If that knot will let me. The hardest part with flossing ortho is if the patient has a lot of inflammation underneath the brackets. At this point, I always will use my cotton tip to help grab the floss threader to get around that inflamed gingiva. And then you just do the best you can. Sometimes there's so much gingiva that you can't even get your floss threader through. So hopefully your scaling has disrupted the biofilm enough that it'll start to heal. So, especially in the molars, but I'm going to show you up here on an anterior tooth to make it a little bit easier to see. I like to floss it between the teeth, and then if I can't reach with my fingers because it's really tight, I'll grab a cotton plier and just help pull it through. And then you're just going to floss as you normally do with your C shape.
This might just look like a little piece of plastic, but inside every Invisalign clear aligner, there's a whole lot of technology. Your journey could start with a simple scan, giving you a glimpse of what your future smile could look like. Like what you see? First, your provider uses cutting-edge software and technology to check you're suitable for Invisalign treatment. Every shift in your teeth is planned out from beginning to end, using 3D technology to calculate just the right amount of force needed, creating a digital roadmap to get you the results you want. Next, we take that roadmap and bring it to life, using 3D printing to create your custom aligners. Our aligners stand out from the crowd. Only Invisalign clear aligners are made with specialist SmartTrack material, developed by biomechanical engineers, which is trimmed to fit your gums perfectly. That means greater comfort for you. Our flexible aligners hug your teeth closer for a better fit, accurate movements, and of course, a beautiful smile. Invisalign has shaped 5 million smiles worldwide, more than any other clear aligner brand. Each of those smiles has made our system smarter, helping to reduce treatment times dramatically. We've put 20 years of research into every Invisalign clear aligner. That's a whole lot of technology for a little piece of plastic.
So, there are times during dental treatment that the topic of nutrition may come up as it pertains to the overall health of our patient. how it's affecting their dental health, or even post-operative instructions. Physiologically, your salivary glands produce saliva as a mildly alkaline secretion, has about 95% water. It has three main functions. It's to lubricate your tissues when you speak, aid in swallowing your food, and they even protect your tooth structure. And while even though your saliva plays a really significant role in these processes, if, say, you're only consuming fermentable carbohydrates and sugars, it can only do so much to protect your teeth from decay. Now, let's stop and talk about fermentable carbohydrates. What are these? They're sugars, they're fruits, cooked starches like breads that are broken down by bacteria and result in an acidic byproduct. I know, all the good things in life. These acids themselves can actually penetrate into the hard tissue of the tooth, the enamel, and dissolve some of the minerals that your teeth are comprised of. Now, with saliva containing calcium, phosphate, and fluoride, and with maybe the decreased production in saliva, can actually result in dry mouth, also known as xerostomia for the technical term. It's the condition of not having enough saliva to keep the mouth wet. Dry mouth can happen to anyone occasionally, for example, when you're nervous or stressed, but certain medications and medical treatments can also reduce the production of saliva, which thus increases the risk of decay, especially if your nutrition isn't where it should be. And that's where proper nutrition and oral hygiene must be of the utmost importance to this patient's. When fermentable carbohydrates are eaten more frequently, more acid is produced, and the risk of decay increases. The intake of water and processed beverages in the United States provides about 75% of a person's fluoride intake, which is the systemic process of fluoride being absorbed into the intestines and then into the bloodstream and transported to the tissues where it's needed, versus a topical application through fluoride varnishes and toothpaste and mouth rinses. Rest assured, the body really does a good job of taking care of itself. If you were to ingest fluoride and say your body didn't need it all, it's going to actually excrete this excess fluoride through your kidneys, feces, and even the skin itself. All right, another confession time. I have a sweet tooth. I love sweets. But the thing is that sugars in your food and drinks play a major role in dental caries developing. The bacteria within the plaque that's on your teeth actually take that sugar and use it as an energy source, allowing them to release that acidic byproduct, basically like a waste product, that breaks down and dissolves and demineralizes the enamel. And locating this culprit of decay may not be as easy as just looking at the label, because there's a lot of different forms of sugar, especially in our processed foods, that are going to increase that risk of dental decay. Some of the different types of sugars used in processed foods are going to be your brown sugar, corn syrup, fructose, maltose, sucrose, molasses, malt syrup, table sugar. There's all kinds of ways that sugar is being added into our foods. You got to keep an eye out for all of those. Discussing proper nutrition and how these different types of sugars play a role in this patient's caries susceptibility, so their risk of getting it, may be something that either the dental hygienist or yourself are in charge of when it comes to patient education. Don't get me wrong. I'm not saying you can't ever have something yummy and sweet, because I have a sweet tooth as much as the next person. But if I were to consistently and all day ingest sugars and not have the proper oral hygiene, and on top of that, I could be asking for trouble. Then add in the possibility that I might be on several medications that reduce my salivary flow. Now we're cooking with oil, but not in a good way. Now, it has been said that sugary foods can actually have a similar effect on the body to drug addiction, meaning like we crave sugar and we can have sugar withdrawals if we were used to consuming large amounts of it on the daily and then just all of a sudden stop, you'll see a change in your behavior. You're a little bit more cranky. So, sugar itself, we really want to make sure that we're being minimal with. Now imagine eating spoonfuls of sugar. Would you sit at the lunch table with a bag of sugar and just eat it bite after bite after bite? Well, you may be surprised, or maybe not, to know that you're basically doing that every time that you sit down to a meal with a sweet drink in hand. If we're looking at the comparison between a water or a purple Fanta, I have to say, best flavor of them all. But if you're looking at that, you have quite a bit, to the tune of about 9 teaspoons. So don't go take a teaspoon out of your drawer and scoop up sugar. Would you sit there and just eat 9 of them in a row? My guess is probably not. But that's what we're getting every time we get pop, every time we hand a pop to a young child. That's what they're consuming. On top of the public maybe not having the best education when it comes to proper oral hygiene practices, they may be going days without brushing their teeth or flossing, or they're just continually eating and drinking these type of things throughout the day. I'm not here to condemn anyone. I've had my fair share of sodas. I told you, Fanta, the best flavor of them all. What I want to do is educate you as the dental professional so that you can have that healthy conversation with your patients if needed and discuss how their eating habits are negatively affecting their teeth without shaming them and ultimately their overall health. We know teeth and the body are not separate systems. They're interconnected and require that homeostasis for our patients to be healthy. But some patients don't realize that what they're eating and drinking are affecting their teeth, and their teeth can in turn affect their overall health. It's our job to compassionately convey this educational material to them with the hopes that they are going to implement that into their daily. But sadly, it's not just sugary drinks where we're going to find that sugar. We're going to find it in every place, such as pizza, orange juice, bagels, milkshakes, and even corn. There's always the debate on whether or not we like natural sugar or sugar-free options or sugar replacers. There's a lot of research going on right now looking at the potential link between sugar-free options and cancer. This definitely needs a lot more research. It's in the early stages of it, but we do know that consuming lots of sugar can cause obesity, which is a strong risk factor for various cancers. And obesity also increases the risk of heart disease and inflammation that may be linked to increased numbers in depression. But it's not just sugary drinks that we're saying are bad. We're not saying fruits and vegetables aren't bad either. You just need to think about balance and what you want to fuel your body with. One of the things I always tell my kids is think of your body similar to that of a vehicle. If you're driving a diesel vehicle, you're not going to put gasoline in it. It's not the right fuel. It's not going to work the way that it's supposed to. It actually is going to do some detrimental damage to that vehicle. It's mindfulness that we're really implementing and emphasizing when it comes to nutrition and dentistry. Here we are again, the end of your second virtual training session. Great job. I know this was challenging. We learned a lot. There were a lot of skills that we were teaching you that we're going to apply in the clinical. So things like the Tafelmeyer and the syringe. Obviously, you don't have these items on hand at home for you to practice with, and they aren't things that you're going to be able to take home. So you will want to make sure that when you're in your clinicals, you're going to stay focused, you're going to stay on task, and practice the skills at each station, asking questions where needed, helping out classmates on things that maybe you're grasping and they're struggling with too. You can always pause your videos, go back and then work through these. These are all going to be ways that you can continue to understand the material. All of the week's training sessions will be up the entirety of the 10 weeks,
So if you ever want to go back and review a specific topic, you can go back to a previously learned virtual trading video. Here I would take a moment to pause and open up your workbook and pull out your clinical charting sheet because we're actually going to do some interactive practice together.
We're going to start off by charting a surgical extraction, which doesn't always entail that it's an easy extraction, just simply that the tooth is already erupted. So let's chart that with tooth number 1. Tooth number 1 is a simple extraction. If you think simple extraction, simple line through the tooth. Tooth number 2, an MO. We're going to chart the occlusal surface and the surface closest to the midline. So those interproximals, those little elephant ears, which one's pointing towards the midline? That's going to be your mesial. Number 3, chart an occlusal right in the center of the chewing surface. Number 4, a disto-occlusal, a DO. So when you're seeing these shorthands of the letters, these are the shorthands for the surfaces of the teeth. So a DO is a distal, away from the midline, occlusal, which is the occlusal chewing surface of a posterior tooth. Number 5, an MOD, mesial-occlusal distal. Mesial, occlusal, distal. 6, the distal facial. First, we need to pick the facial surface and not right in the center of the tooth, but off away from the midline towards the distal surface. 8 is going to be a class 5 facial. Number 9, an incisal facial lingual. The incisal edge of the facial and the incisal edge of the lingual. 12 is an MOD, mesial occlusal distal. Same with number 13. 13 is also an MOD. Number 15 is an occlusal lingual, an OL. Occlusal, and then mark the lingual surface. 18 is an occlusal. 19 is a buccal. 20, distal occlusal, DO for number 20. Distal occlusal. 21 is just an occlusal. 27 is a class 5 facial. Make sure that you're marking the facial surface and you're not marking the incorrect side. You don't want to mark the lingual there. 30 is an occlusal buccal. Number 31 is an occlusal lingual. So this is where you have to know that the lingual surfaces on these lower teeth are closer to the tongue or the inner portion of the picture. And 32 is a surgical extraction. And it's a circle around the tooth. The Palmer notation system. The Palmer notation system is the numbering system utilized in the orthodontic specialty. The ortho office does not require any specialized training, so when you leave our program, you will be able to jump right in and start working. The numbering system that they use is very particular to their specialty. If you're working in other avenues and specialties of dentistry, you more than likely won't ever work with this numbering system, but it is still very helpful information to know. The orthodontic numbering system, you can think of it a lot like if you are trying to straighten the teeth, you are going to want this in the most aesthetic way possible. So you would want
the maxillary and mandibular to be mirror images, but also the right and the left to be mirror images. So instead of numbering the teeth 1 through 32 or A through T for the pediatrics, we utilize them from the midline out. That way, from the midline out, everything is symmetrical like a mirror image. All of your central incisors of the adult dentition are 1s. All of your lateral incisors are 2s. Your canines are 3s. Your first premolars are 4. Your second premolars are 5s. Your first molars are 6. Second molars 7, and third molars 8. So you're going from the midline out. But then that can be a little confusing because then we have 4 of each number in the mouth. And that's where the splitting of the quadrants, or the 4 areas of the mouth, come into play. Think of it as the upper right quadrant as quadrant 1, upper left 2, lower left is quadrant 3, and lower right is quadrant 4. Now we could number it as 1, 1, meaning the first quadrant and the first tooth in it, or 1, 2, with a semicolon between them, meaning the first quadrant and second tooth, which in all of our other avenues of dentistry, we would typically call that tooth number 7. So if it helps, go over top of these teeth, starting with what would be the patient's upper right. So in this case, if we're looking at the screen, it's on the left side of the screen. You'll see where it's written right. Backwards thinking, because it's as though the patient is laying in front of you, mouth stretched wide open. It's the patient's right. So it's opposite on paper and on screen. We would start with number 1, work our way over to the other side with 16, drop down to 17, all the way to 32. And that's going to help us to translate between one system and the next. We can do the same thing with the pediatric mouth, but this time we're using letters rather than numbers. So all the centrals are A's, laterals B, cuspid C, first molars are D's, and second molars are E's, working from the midline out. The little brackets that you see by the numbers and the letters are what are helping you to identify which quadrant. And so as you can tell in the little illustration in the center, it's as though we draw a mark down for the midline and through the middle of the picture like it's the upper and lower. So you can kind of tell if the bracket looks like a backwards L and there's a 2 on it, that would be what we normally call tooth number 7. If it looks like a normal L with a 5, that's what we would typically call tooth number 13. So it's kind of a translation from one system to the next. And you can actually find this in your textbook on the back inside cover. So the hard part on the back of the book, there's all the different numbering systems. You'll see illustrations of the teeth. It's a fantastic resource of the Palmer notation system. Whenever you're working with a posterior class 2 restoration, which is something that involves the interproximal surfaces, so those are those mesial and distal surfaces that are down in between the teeth, we need to utilize something called a matrix system. The matrix system is designed to create a temporary interproximal wall, so something that separates that interproximal surface of the tooth that is diseased from the tooth adjacent to it. So as you're placing that filling, it doesn't end up sticking to the tooth next to it or bonding to the tooth next to it and creating one really large tooth. So the posterior matrix system that's most commonly used is the Toffelmeier matrix retainer or matrix system. This mechanical device actually holds the matrix band, which are these little silver boomerangs, into place, creating that temporary interproximal wall. There are different types of bands that are available. So the bottom one that is smooth is going to be our universal band, whereas the top one that has those extra little winged protections are what we call the extension band. So these are typically used when you are working with a really deep restoration that can extend below the gum lines. They come in different gauges, so essentially are they considered soft or rigid or hard, is how flexible is that metal. So this one's pretty soft and flexible, whereas this one is a slightly bit more dense material, so it's got a little less play to it, so it doesn't crease as easily and it stays in place a little bit, more firmly. Prior to the band being placed on the tooth, what a lot of dentists and EFTAs prefer to do is to take an instrument like a burnisher and to rub it along the sides of the band to create a more contoured shape, more natural to the anatomy of the tooth. As an assistant, without being trained as an EFTA, we are simply setting up this Tafelmeyer prior to the appointment beginning. So you're not actually putting this on the mouth, which later we'll see what that looks like inside the mouth, but we are setting it up when we look at the schedule and we see tooth number 30 has an MO, tooth number 20 has a DO, so then we know that they're going to need some sort of a posterior matrix system. The retainers also come in some variations. So we've got ones that are specific for the mandible. You'll see that it kind of has that angled part. And then we have our one that we're going to use in class that's more of that universal. Now there are different parts of this Tafelmeyer that we want to kind of talk through here so we understand when I'm using this terminology, what exactly am I talking about? When we talk about the knobs, we're talking about these two on this end. The smaller knob is what screws the spindle, so the screw-like structure, and pinches the band into place so it won't fall out. The large knob, as you twist it, you'll notice that it moves the box, we call that the vise, up and down the spindle, which then in turn changes the diameter of the band. Obviously, then this is called the vise, and in the vise, there's a little horizontal slit that goes through it, and that's where the tail ends of your bands will go. And on this end, we have these sets of prongs. We have one set, and we have our second set. And you'll notice that it kind of has a U shape to it. Anytime that we're setting this up, whether it's for the upper, lower, right, or left, you're going to want to make sure that that U is facing up towards the sky. So this is what you should see whenever you're setting up the Tafelmeyer. You should also have your band always shaped like a V. So we don't want to see a tint, because what happens is if you take these tail ends, which is this end and this end, and you close them together to create an uncreased loop, like so, you'll notice that on one end of that loop, it's a little bit smaller in diameter than this end. You can kind of see it funneling up. That funnel needs to be directed towards the gum line, and so does these prongs. So when you're holding this up like a U, that's for the upper arch, and when you're holding it down like an N, that's for the lower arch. What that's going to ensure then is that the smaller end of that loop, this end here, that's the end that's going to go towards the gum line. If you think about the shape and anatomy of a tooth, as we get towards that gingival third, which is the gum line area of the tooth, it does get a little bit smaller in diameter. And so this creates that natural shape of the tooth. We take our uncreased loop without flipping it and turning it as we go. So always making sure that if we open it, it still looks like a V. We touch tail end to tail end. We're going to take those tails and we're going to slide it right down into the horizontal slit and allow it to go straight through. Now, if for some reason it doesn't want to go all the way down, what probably is occurring is that the spindle, so the screw, is in the way. So it's all the way up inside the vise and it's just not allowing it. So mess with the small knob, and then it should slide down without any interruptions. But we don't want to leave it like this because right now it's really loose, it could pop off, and it's not going to be useful. So if you want to tighten that band into place so it won't pop out, you'd use the small knob. But before we do that, let's determine where this band actually needs to be directed, because right now it's not going to be useful for any particular region in the mouth. So if I'm working in the upper right hand quadrant, so that's tooth numbers 1 really through 5, we don't use this on an anterior tooth, we're going to take this band, we're going to keep our thumb on this little horizontal slit so it doesn't pop out. I'm going to take my band out of not the first set, but the second set of prongs and use those as directional prongs that will turn it to the right side. So upper right to the right. Upper left, we're going to take that and we're going to turn it to the left side. So upper right to the right, upper left to the left. Now when this fits inside the mouth, this is a lower arch, so it's going to look a little bit different than me holding it in, but this is what it's going to look like inside the mouth, where the retainer itself is on the buccal surface. The band is always facing towards the tooth you're working on. If it's a lower, in this case, the U is facing down to make the letter N essentially, and the smaller end of the band is going towards the gum line. But if I were to take something that is set up currently for the upper left, and you know that because the band's to the left, and if it's for an upper, the U shapes up, but if it's a lower, it faces down. If I try to put this in the lower left quadrant, look what happens. That is now not on the buccal surface, and if they try to bite together, they're gonna bite on the retainer. So even though this works for the upper left, because the band's to the left, it will work for the lower right. So upper left to the left, upper right to the right, in opposite quadrants work together when we're talking about the uppers versus the lowers. Now, what a lot of dentists and EFTAs will use in addition to the retainer system is a wedge. So this wooden wedge comes in different sizes and variations and colors, but it typically is wedged in through the lingual embrasure. So that's that little triangular space between your teeth and gums, in between teeth. It gets wedged in there and it helps to create a really tight contact. It ensures that the band alone doesn't pop out, and it creates the correct contour with that. So it gets pressed in there through the lingual embrasure. So you know exactly what to set up for based off of looking at the patient's chart. Then what happens is after the tooth is numbed and prepped, you hand the doctor the retainer, they go to place it in, and you'll notice there's some frustration with these retainers because they actually have to get this band around the tooth. So if I know I'm working on a molar, I'm gonna go and keep my band really large. But if I know I'm working on a premolar, what I can do is actually take that large knob and turn it to make the diameter just a little bit smaller. You don't want it the exact size because we still need to be able to fit it around the tooth. And once it's on the tooth, they'll cinch it even tighter, almost like cinching a belt close. So they'll keep turning the knob until that gets tighter and tighter around the tooth. But it saves them some time and they don't have to adjust as much. So in review, this is your Toffelmeyer matrix retainer. It is a posterior matrix system designed to create a temporary wall between the tooth that it surrounds and the tooth adjacent to it. So as you place that mesial or that distal restoration, it doesn't stick to the tooth next to it. When you're putting it in, you're always going to want to make sure that the prongs are facing skyward so that you can see everything. So you should be able to see the vise and the horizontal slit. Your band should look like a V, not like a tent. So what happens a lot of times is we close it together, and then when we go to put it in the retainer, we do one of these numbers, a little acrobatic act, and we don't want to do that. So we're going to take that and we're going to slide it straight down into those little horizontal slits without creasing this. That's important. If you crease it, this is not going to create the natural contour of a tooth, so make sure that you're not creasing it. If you want this to work for the upper right, then what you'll do is you'll take that band and you'll direct it to the right. If we want it to work for the upper left, the band is directed to the left. Noticing that the smaller end of that band, that smaller end of the loop, is facing the same direction as the prongs, which would be near the gums. When we're done and have it positioned where we want, we're going to tighten it into place with this screw. If we want to change the diameter, we use the larger knob. And opposite quadrants are the same. So if this works for the upper left, this also works for the lower right.
Going through the parts of the aspirating anesthetic syringe. What we're going to look at first is going to be the threaded tip. This is where you're going to screw on your needle. Your piston, which goes up and down inside of the syringe with the harpoon on one end and the thumb ring on the other, where the dentist would hold, or even the hygienist would hold, to actually plunge and put the medication into the patient's mouth. You've got blue and yellow needles. Typically your blue is going to be for your maxillary and your yellow going to be for your mandibular. With the clear end, being your hub end that's screwed onto the syringe, and the blue the injection side. Looking at your anesthetic carpules, you'll look for whether or not it has epinephrine in it, the expiration date, looking for any kind of discoloration, bubbles, looking as though some of the material has been used, because we do not want to use a carpule that's been used on another patient. You could also tell if it's been used by looking at the top in that diaphragm to see whether or not you see a puncture from the needle. We definitely don't want to use that on one patient to the next. You also want to utilize, if your office has it handy, some kind of safe needle recapping. Let's start by taking off the hub end of the needle. That's the clear side of the needle. Carefully taking the sterile needle, you're going to screw it onto that threaded tip, making sure that it's screwed completely down where the plastic meets the metal without over tightening it to where it's really difficult to take off later. Then you will place your hands on the piston, pulling it back. Otherwise, you're not going to be able to fit your carpule in there, and you'll know because you won't be able to get it in. But you're going to pull it back so it's out of the way, placing the rubber end towards the harpoon, the little part that looks like a fishing hook, and the metal cap towards the needle. And you'll notice that it's kind of loose. So you're going to firmly hold that and spank the thumb hole so that it engages with the harpoon. Always make sure that you're handling needles safely. These I really like, the protectors, because if you were to go to recap it, acts like a shield so you can't accidentally stick yourself. One way that you can check whether you've assembled it properly is to give it a little bit of a squeeze to make sure that that fluid is coming out. But let's say that your office doesn't have one of these needle protectors. You can simply scoop and press that lid on as a safe way for you to recap that needle without injuring yourself. Now, to disassemble it, you essentially work backwards. You're going to quickly pull back on that piston, slide down and remove the anesthetic, which sometimes that rubber stopper gets stuck on the harpoon, which is fine. Just make sure you're not using your finger to pull it off the harpoon because that's really sharp and can cut you. That can be disposed of. And the needle is going to be unscrewed. Now, I like to bend the needle when I take it off and put it directly into our sharps container. Do not try to recap it with the hub end because you can accidentally stick yourself in that side. It's still considered contaminated. So you'll put that directly into your sharps container, which should be located in each of your operatories. You can put your carpule in there also.